on to the next session, I would like to invite the chairpersons of the session. I would request Dr. Bharat Patel, a senior surgeon from Bhavnagar, who practices at Akar Hospital, to take his position on the dais. He's been practicing since 1987 as a general surgeon, and he was the first laparoscopic surgeon in Saurashtra. He's an expert in yoga too. We would now request on stage Dr. Bharat Kakadia, who is an ENT surgeon and practices at Senses Hospital, who is the president IMA GSB 2023-24, to take his seat on the dais. And we would request the chairpersons to then introduce our speaker for the day, Padma Shri Professor Dr. Sudhir Shah.
Good afternoon, everyone. So, before...
Should we start? Yeah. Professor Dr. Sudhir Shah. There is hardly require any introduction. He is our proud neurophysician from Ahmedabad, Padma Shri. And our today's topic is about happiness and laughter. મિત્રો, ઘણા બધા ગંભીર એકેડેમિક સેશન અને છેલ્લે આપણે પ્રોફેશનલ ઇન્ડેમનિટી અને જે કાંઈ આપણા ક્રિમિનલ અને આપણી જવાબદારી વિશે વાત થયા પછી એક હળવો ટોપિક આપણે અત્યારે છેડવાનો છે. અને આખો દિવસ પેશન્ટના દુખડા આપણે સાંભળીને ઘણી વખતે આપણે પણ બહુ ગંભીર થઈ જતા હોય છે. એટલે આપણી પ્રોફેશનલ લાઈફની અંદર પણ આપણે લાફ્ટરની બહુ જ જરૂર હોય છે. એવા સરસ ટોપિક સાથે ડૉક્ટર સુધીરભાઈ આપણી સમક્ષ હાજર થાય છે. પ્રોફેસર છે, HOD છે, NHL મ્યુનિસિપલ મેડિકલ કોલેજમાં ડાયરેક્ટર ન્યુરો સાયન્સીસ સ્ટર્લિંગ ગ્રુપમાં છે, કન્સલ્ટન્ટ ન્યુરોલોજિસ્ટ ટુ HE, હિઝ હાઇનેસ ગવર્નર ઓફ ગુજરાત, પાસ્ટ એક્ઝિક્યુટિવ કમિટી મેમ્બર એટ ઇન્ડિયન એકેડમી ન્યુરોલોજી. અને એટલી બધી એમની ઉપલબ્ધિઓ છે કે આપણે એ ઉપલબ્ધિઓમાં વધારે ડિટેલમાં ન જતા હું અત્યંત ગૌરવની લાગણી સાથે ડૉક્ટર સુધીરભાઈને આપની સમક્ષ રજૂ કરું છું. ડૉક્ટર સુધીરભાઈ.
Thank you very much, chairpersons, and I am extremely grateful to GIMACOM 2023 post holders, Dr. Mahavir Singh, Dr. Mehul Bhai, and all executive committee members, and all dear friends. હમણાં જ્યારે આ વાત ચાલતી હતી ત્યારે મારી બાજુમાં એક ભાઈ બોલ્યા કે ડૉક્ટર થયા છે તો માર તો ખાવો જ પડે ને. મને લાગ્યું કે ડૉક્ટર થતાં પહેલાં આપણે વિચાર કરવો પડે. આટલા ઇમ્પોર્ટન્ટ ગંભીર ટૉપિકનો એક અધર એન્ડ છે ને આપણે એકદમ એક્સ્ટ્રીમલી અધર એન્ડ ઉપર હવે જવાની કોશિશ કરીએ છીએ. સાહેબે જેમ કહ્યું, પરસ્યુટ ઓફ હેપીનેસ આપણા માટે સૌથી ગંભીર ટૉપિક આ છે. પણ આપણી કોઈ પણ ટેક્સ્ટ બુકમાં, કોઈ પણ લેક્ચર્સમાં, કોઈ જગ્યાએ આના વિશે કશું જ આપણને શીખવાડવામાં આવતું નથી. દેટ ઇઝ વાય આઈ હેવ સિલેક્ટેડ ધીસ ટોપિક. મારો તમને પહેલો એક સવાલ છે, તમારામાંથી કોને હેપી થવું? જેને હેપી થવું એ હાથ ઊંચા કરો. ઓ, એવરીબડી વોન્ટ્સ ટુ બી હેપી. દેન બી તમારે ખુશ થવું તો થાવ ને ભાઈ, તમને કોણ રોકે છે? રિમેમ્બર, યુ આર ઇન ચાર્જ ઓફ યોર હેપીનેસ એન્ડ નોટ એનીબડી એલ્સ. આપણને કોઈ માણસ દુઃખી કે સુખી કરી શકે જ નહીં. આપણે ખોટી ભ્રમણામાં જીવીએ છીએ કે ફલાણાએ આમ કર્યું અથવા આવું બન્યું એટલે હું દુઃખી થયો. આ પ્રેઝન્ટેશનમાં હવેની નેક્સ્ટ 38 મિનિટ્સમાં હું તમને પ્રૂવ કરી આપીશ અને એનો રસ્તો બતાવી દઈશ અને ન્યુરોસાયન્સના બેઝ ઉપર બતાવીશ. I will need your complete attention, please. So nobody can make you happy or unhappy. Decide every morning that you are in a good mood, and happiness is a choice. Also, to make others happy is also a choice. આજે જો મને કહેવામાં આવ્યું તમારે લેક્ચર આપવાનું તો હું એપિલેપ્સી ને સ્ટ્રોક ને બધા ઉપર પછાડી શકત, પણ એને બદલે મેં હેપીનેસ ચોઇસ લીધું કારણ કે આઈ વોન્ટેડ ટુ મેક યુ ઓલ હેપી. ઓકે, એન્ડ સો યુ કેન ઓલ્સો ડુ દેટ. Be happy and make others happy. Happiness is a journey and not a destination. Another important thing. There is no better time to be happy than right now. So fasten your seatbelt and start the journey of happiness with me. તમે એમ કહો કે મને 5 કરોડ રૂપિયા મળી જશે એટલે હું સુખી થઈશ, અથવા તો હું મિનિસ્ટર થઈશ તો સુખી થઈશ, કે ફલાણું થશે, એવોર્ડ મળશે તો સુખી થઈશ, એ બધું ખોટું છે. The moment you get that, your goal will shift, and then again your mind will play a game with you. So never do that. What is the purpose of life? Purpose of life is to live, to be happy and make others happy. But when I am telling this to you, it doesn't mean that I am the happiest guy on this earth. I also make mistakes, but day by day, after understanding the whole philosophy and neurology of happiness, I understood that I can become more and more happy day after day. And I'm sure this will happen with you also. So, in a very short time of this 40 minutes or whatever, I am going to cover lots of things. First, we'll define happiness, then neuroscience and psychology of happiness. Why we are unhappy, we'll find out. And then, after understanding the basic, in the last 20 minutes, we will find out what are the ways to become happy. Those are very important, simple, and yet forgotten ways. Aristotle long back said that happiness is the meaning and purpose of life. The whole aim and the end of existence. There is nothing beyond happiness. આપણે દુનિયામાં જે કંઈ પણ કરીએ છીએ માત્ર આપણા સુખ અને શાંતિ માટે કરીએ છીએ. Forget those psychotic or people who have wrong intention. અને એણે કહ્યું કે 4 વસ્તુ જોઈએ: good health, good relationships, good virtues and optimum money. Indian philosophy એનાથી પણ આગળ જાય છે, એ આપણે જોઈશું પછી. So, good health, good relations, good virtues and appropriate amount of money. 10 કરોડ 15 કરોડ થયા પછીનું પૈસા જે છે, અથવા તો 5 કરોડ પછીના પૈસા છે, કંઈની વહીવટ છે, એમાં કોઈ મજા નથી અને સ્ટ્રેસ છે. એટલે તમારી લિમિટ તમે નક્કી કરો, બરાબર ને? So, this is very important. I wrote an email, Chairman Sahib, I wrote to my mentors, what do you think, what makes you happy, what is the goal of your life? 2002માં મેં આ ઈમેલ લખેલો 150 સિનિયર્સને. એના ઉપરથી મને ખબર પડી કે લોકોની હેપીનેસની ડેફિનેશન અલગ અલગ છે. ઇટ ઇઝ નોટ દેટ એવરીબડી થિંક્સ in terms of happiness in one way. There are people who think of pleasure, there are people who think of joy, and there are people who think of bliss. So, depending on their mental attire, sattva, rajas and tamas, they find out what is their happiness. Like there are people who want to eat, drink and be merry. ખાઓ પીઓ, મજા કરો, ક્લબમાં જાઓ, પત્તા રમો, ન્યૂઝીલેન્ડ સ્વિટ્ઝરલેન્ડ ફરો અને જીવન પૂરું કરો. આ જે 5 ઇન્દ્રિયોની સાયકોલોજી છે, those sensual, instinctual and physiological things are called pleasure. The happiness is sought from outer world. સુંદર મજાનું મ્યુઝિક સાંભળવું, સુંદર જગ્યાએ ફરવું, સરસ ખાવું પીવું અને સુગંધીવાળા પદાર્થો. This is all happiness is for them. They don't have any other. Please, no noise, please. Okay. When we did fMRI of these people during their physical activities of pleasure, we found out that the areas of the brain pertaining to that instinctual physiological thing got increased blood circulation. This is fMRI, so activity, metabolism. And like when they were looking at some beautiful visual item, they had visual cortex getting increased activation. So, for hearing, for music, there was auditory area and so on. Anyway, the chemicals responsible for that were dopamine and serotonin. And you know the circuits, which I will not go into details because of constraint of time. But you see, dopamine is a reward molecule. Whenever you get something good, you always try to get that next day, the other day, every day, and you want more and more. This more and more psychology is due to dopamine circuit. And what remembers this is your serotonin and acetylcholine. And these couple things, make you crave for things. The substance abusers, for example, gambling or shopping, all these are reward circuits. Dopamine we can get from apple, beet, cucumber, green leafy vegetables, honey, cheese, etc. An apple a day keeps the doctor away. But if the doctor is cured, forget the fruit. Okay? So serotonin you can get from fruits, vegetables, bananas, light stretching exercise, and soothing music. The next level is joy. So this is a sensual level related to your five senses. When you are slightly human, that was a basically animal instinct, but the human instinct is to do something for ourselves and others. So it comes from the inner world as well as it has some outer world dependence also. It's a psychological feeling. That was a physiological, this is psychological. There are desires here, but these are refined desires. Like through service to mankind, success, creativity, achievements, social interactions, recognition, simple spiritual practices, all these bring joy to us. I'll give an example. So achievement, degrees, certificate, holding conferences, gathering people, having a lot of fun with friends, all these things is joy. When I am creating music, I am performing on stage, it is joy for me. But for you, when you are listening to my music, it is pleasure for you. So this is the difference. Creativity brings joy. And then when we do fMRI of these people, we find the different set of brain areas are activated, and this lasts for much longer time. If you eat something good, you will find pleasure for few minutes, and there will be craving next day. But if you do joyful activity, it will last much longer, a day, 5 days, or maybe month or more. So that is why joy is quite human. એનો અર્થ એ નથી કે ખાવું પીવું મજા નહીં કરવાની. That is all right. But at least as a human being, we have to impart meaning to people. We have to be creative. We have to do service to mankind. We have to help people. And that is level of joy. But there is a catch. The catch is, joy એટલે શું દાખલા કે તમે ખૂબ પૈસા કમાયા, એવોર્ડો લીધા, બધું બરાબર છે. પણ આજે શું છે, આ બધી વસ્તુઓ, these are transient, impermanent. If tomorrow તમારા બધા પૈસા જતા રહ્યા, કોઈ શેર બજારમાં નુકસાન થયું, આ બધું ડૂબી ગયું કાલે, અથવા તો કોઈ કારણસર તમારા બદનામી ચાલુ થઈ, તો whatever joy you had, because it is dependent on outer world once again, this will not make you happy anymore. The joy is also not permanent. It does not last that long. And therefore, even though joy is a little longer lasting activity, it cannot give you permanent happiness. So the chemicals here are oxytocin, vasopressin, prolactin, and others. So friends, we have to move further, something better than that, and that is long lasting, more or less permanent happiness, and that is called bliss. It's the highest stage. Here mind and all its activity ceases. How? We'll see later on, when we find the keys of happiness. Our consciousness becomes identified with the universal consciousness. It's an experience of just being. It's a meditative state. It is totally self-dependent. It has nothing to do from outside world. બીજો માણસ આપણા વિશે શું કહેશે, કરશે, કઈ કોઈનું માન આપશે, નહીં આપે, એની જોડે એને કોઈ લેવા દે નથી. Those elevated saints and the avatars like Mahavir, Buddha, Krishna, Ram, they all had achieved this permanent meditative state. And we can also get this transiently by practicing mindfulness practice and other things. And when we did fMRI and SPECT of these people, we found the beautifully small area of the brain, the left parietal circuit, which was activated. And this had a profound, long-lasting effect. It can, if you do it daily, as for example, if you do mindful practice or some kind of meditation and prayer and sadhya, etc., this will make us permanently happier day by day, and we can remain peaceful without any disturbance. The chemicals here are not dopamine, not serotonin. They are endorphin, encephalins, GABA, endocannabinoids, etc. And the beauty is, along with this kind of permanent happiness, you have always peace. કોઈ માણસને જાણવું હોય કે મને જે સુખ પ્રાપ્ત થયું છે એ સાચું છે કે નહીં, તો એનો એક પેરામીટર એ છે કે એની સાથે એને શાંતિ મળે. જે સુખની સાથે શાંતિ આવી હોય, peace of mind is generally associated with happiness of bliss type, and it gives you contentment. So that is your self-check test. So friends, we have got a little of the background, pleasure, joy and bliss, and I'm sure you are all doctors, you know how to test that. Test our happiness index, GDP, human DI from the economic viewpoint, but we as neurologists do magnetoencephalogram, fMRI, SPECT, PET, etc. And we have found that different types of happiness reside in the different areas of the brain. Like laughter responses and pleasureful activities are in the left prefrontal area. Some beautiful incidences in the right temporal area, etc., etc. So that was my first part. Then my major concern, why I am here today all the way traveling from Ahmedabad, I have seen in my life, friends, I am really concerned that we as doctors live 10 years less than the normal population. I am sure you know this data. We are all very unhappy despite doing a lot of work and a lot of service to humanity. Somehow we are misregarded, we have been coached, and the discussion we had in previous session. So why? We have to heal ourselves. We are trying to heal people. Actually, we need to heal ourselves. I was thinking loudly that there are two types of living beings in the world. One are happy people, and number two, doctors. Friends, life is larger than medicine or professional business. આપણે બધા ડાક્ટર તરીકે સવારથી રાત સુધી એકને કર્યા કરીએ છીએ અને જિંદગીની ખરેખર બરબાદી કરીએ. આ વાત મને જ્યારે 2002માં 2005માં ખબર પડી ત્યારથી હું ચેતી ગયો અને મને થયું કે મારે આઈ શુડ શેર વિથ માય ફ્રેન્ડ્સ. સો બે મોલેક્યુલ વધારે તમે શીખશો અથવા એકાદ રેર સિન્ડ્રોમ ગોખી પાડશો તો તમારું કે પેશન્ટનું કંઈ ભલું થવાનું નથી. બહુ તો રિફર કરી દેજો. તમારે શું ચોપડું વાંચી લેજો. પણ તમને પ્રેમથી તમારી વાઈફ કે હસબન્ડ સાથે વાત કરતા નહીં આવડે, તમારા બાળકને પ્રેમથી તમે બેસીને એની મુશ્કેલી નહીં સમજો, તમારા પેશન્ટ અથવા તમારા સર્વન્ટ સાથે આનંદથી વાત નહીં કરો ને ગુસ્સો અને ઠઠા કરશો, આઈ થિંક યુ આર લિવિંગ અ મિઝરેબલ લાઈફ. ઓકે, સો બેસ્ટ થિંગ કે હવે ચેતી જઈએ. જે પણ આપણામાંથી ભૂલ કરતા હોય એ લોકોએ આ વાક્ય યાદ રાખવાનું. આપણી પાસે દુઃખી થવાના 1000 કારણ છે. ડૉક્ટર લાલા સાહેબ મારા મિત્ર છે, મને લઈને આવ્યા. અમે ઘણીવાર બધી ચર્ચા કરીએ કે ડૉક્ટર તરીકે હું 7 ઘોડા ઉપર સવાર છું. એકેડેમિક્સ, રાઇટિંગ લિટરેચર, ક્રિએટિંગ રિસર્ચ, ડુઈંગ lecturebazi to many people, whether they are interested or not. But I go on giving lectures, writing books, and then teaching my DM students and doing clinical practice for 10 hours or 8 hours. અરે બાપરે, આપણા જેવા મૂર્ખ માણસો દુનિયામાં કોઈ છે નહીં. આટલી બધી પ્રોબ્લેમ, એકેડેમિક સ્ટ્રેસ, પ્રોફેશનલ કેરિયર, મા બાપ, બાળકો બધાની જવાબદારી, હસબન્ડ વાઈફની જવાબદારી, અને એની વચ્ચે દરેક જણને ફેમસ થવું છે, દરેકને પૈસા કમાવા છે, ટ્રાફિક, મોબાઈલ, સોશિયલ મીડિયા, મેડિકલ મેનેજમેન્ટ, મિસઅન્ડરસ્ટેન્ડિંગ, સ્ટાફ મેનેજમેન્ટ, લીગલ ઇસ્યુ, એમાં પાછો પેલો ગવર્મેન્ટવાળો આવીને જીએસટી ને ગવર્મેન્ટના ને કેટલા પ્રોબ્લેમ. હવે તો બધા આપણે જીએસટીમાં આવી ગયા. અને એમાં આપણે ફિઝિકલ ને મેન્ટલ હેલ્થ સાચવવાની છે ભાઈઓ. કેવી રીતે કરવું? આ તો પેલો લક્ષ્ય ભેદ કરતો હતો ને અર્જુન, એના કરતાંય અઘરું છે. અર્જુનને તો એટલીસ્ટ થઈ શકે, આપણું આ કરવું મુશ્કેલ છે. સિવાય કે આપણે ખરેખર કંઈક એવું કરીએ. અને એમાંય પાછું સોશિયલ મીડિયામાં રોજ 2, 4, 6 કલાકની આપણી જે ટાઈમની મુશ્કેલીઓ થઈ ગઈ છે, આઈ ડોન્ટ નો એના જેવું એમ્પ્ટીનેસ અને આઇસોલેશન, ઇમોશનલ બર્ન્ટ આઉટ, રેસ્ટલેસનેસ અને લેક ઓફ કોન્સન્ટ્રેશન કોઈ બીજી વસ્તુ ના કરી શકે. એના બદલે આ 2-3 કલાકમાંથી અડધો કલાક કસરત માટે, અડધો કલાક મેડિટેશન માટે, અડધો કલાક મિત્રને ત્યાં જઈને ગપ્પા મારવામાં જો કાઢીએ તોય આપણે સુખી થઈ જઈએ. પણ આપણે બધા ખોટા રસ્તે છીએ. એને બદલે હું તમને એક કન્સેપ્ટ આપું. આ એક સ્ટડી પબ્લિશ થયેલો કે ભાઈ સુખના કારણો શું છે. આપણે જોયું અનહેપીનેસના કારણો, તો સુખનું કારણો શું છે? તો એણે કહ્યું કે 20% તો તમારો જે જીનેટિક મેપ છે ને એના ઉપરથી તમે સુખી કે દુઃખી છો. 10% જિંદગીમાં જે ટ્રાન્ઝિયન્ટ સર્કમસ્ટન્સીસ બને એને લીધે આપણે સુખી દુઃખી છીએ. 20% માત્ર 20% મની, હેલ્થ વગેરેના કારણે છે. અને 50% આપણી હેપીનેસ આપણી એટીટ્યૂડ, બિહેવિયર, મોરાલિટી અને સ્પિરિચ્યુઆલિટી ઉપર ડિપેન્ડ કરે. હું નથી કહેતો ભાઈ, આ ન્યુરો સાયન્સનો લાર્જેસ્ટ સ્ટડી હાર્વર્ડનો કહે છે. અને રિલેશનશિપ ઇઝ ઓલ્સો વેરી ઇમ્પોર્ટન્ટ. દે સેડ some cause happiness wherever they go, others whenever they go. કેટલીક બુંદ જાય ને તો સારું લાગે આપણને. એવું હું નથી કહેતો, ઓસ્કાર વાઇલ્ડ કહે છે. સમ પીપલ આર બોર્ન હેપી. આ છોકરી મારી બાજુમાં રહે છે, એસએસસીમાં 3 સબ્જેક્ટમાં ફેલ થઈ, એટલે હું ખરખરો કરવા ગયો એને ઘેર. મને અંકલ ગઈ વખતે તો હું 5માં ફેલ હતી, આ તો 3માં જ ફેલ છું. દે આર બોર્ન હેપી. સી ઇઝ અ બ્રહ્મક્ષત્રિય લેડી. અને બ્રહ્મક્ષત્રિય અને પારસીઓના જીન તમે જુઓ તો 90-95 વર્ષ જીવે અને ઠઠ્ઠા મશ્કરી જ કરતા હોય. એમના જીન્સ છે એવા. જ્યારે અધર્સ આર બોર્ન ડિફિકલ્ટ. અને પહેલો નંબર આવ્યો અને હું મળવા ગયો હતો. આ ઠીક છે, એમાં શું છે? એટલે and which are those genes? Science has found out these are the genes. DRD24. તમારો હોલ જીનોમ પ્રોજેક્ટમાં તમે જોઈ લો તમારામાં જીન્સ છે કે નહીં. ના હોય તો મને કહેજો, હું નાખી આપીશ. જીન ચેન્જીસ, જીન એડિટિંગ થઈ શકે છે. સો ઇન્ટ્રિન્સિક હેપીનેસ અકર્સ નેચરલી. મિત્રો, જીન્સ બદલવા માટે કંઈ તમારે એડિટિંગ કરવાની પણ જરૂર નથી. ઇન્ડિયન ફિલોસોફી has taught us કે તમારું humans have genes that can be activated by our positive thoughts, emotions and behaviors. Mindfulness, meditation and altruistic actions, they unlock the DNA code and produce the natural happiness. So these are the ways how I can change my DNA with mindfulness, meditation and positive actions, and I can change my genetic expression, if not genes, with the positive thoughts, emotions, behavioral changes. Okay? So friends, that was genes. Then we come to circumstances. સર્કમસ્ટન્સીસમાં એવું છે, એક વાત તો કે બધા સર્કમસ્ટન્સીસ ટેમ્પરરી હોય. અને ટાઈમ એન્ડ લવ આર ધ બેસ્ટ હિલર્સ ઇન ધ વર્લ્ડ. ટાઈમ એન્ડ લવ, આ 2 વસ્તુથી બધું હિલ થઈ શકે. પૈસાથી કશું હિલ નથી થતું. સો સર્કમસ્ટન્સીસ વિલ પાસ અવે. પણ જે બીજી વાત છે સંજોગોની એ છે કે આપણે બધા બહુ કમિટમેન્ટ કરી દઈએ છીએ. લાલા સાહેબ મારા મિત્ર છે, મને મળ્યા. મને કે સુધીર તારે ભાવનગર આવવાનું છે. મેં કહ્યું ભાઈ શું થયું? તો કે આપણે કમિટ કર્યું છે GIMACOMમાં જવાનું. હવે લાલા સાહેબ મારા મિત્ર જ ના હોત તો મારે આ છેક અમદાવાદથી 4.5 કલાક થયા છે, તો ધક્કો ખાવો ના પડત. જોકે એ વાત જુદી છે કે આજે બધા મિત્રોને હું મળીશ બપોરે. પણ જેટલા કમિટમેન્ટ આપણે કરીએ એટલું વધારે ને વધારે આપણે ગૂંચવાતા જઈએ છીએ. અને એ આમાં જ ધ્યાન રાખવું. Then there were studies કે ભાઈ who is more happy. પૈસાદાર લોકોનો જે આ સ્ટડી થયો એમાં જે ગ્રીન જે પાર્ટ છે, નોર્થ અમેરિકા, ફિનલેન્ડ, ન્યૂઝીલેન્ડ એક્સેટ્રા, they are the happiest people as per the economics are concerned. નેધરલેન્ડ અને ફિનલેન્ડ ને બધા કન્ટ્રીમાં સ્યુસાઇડનો રેટ સૌથી વધારે છે, તો એને હેપી કેવી રીતે કહેવાના? એટલે પૈસાથી હેપીનેસ આવે કે કેમ એક બહુ મોટી બબાલ છે. મની પ્રોડ્યુસીસ શોર્ટ ટર્મ બેનિફિટ્સ, પણ મોર મની વિલ નોટ બ્રિંગ વેલબિંગ. આ એક સ્ટડી થયેલો જેમાં એવું બતાવ્યું છે કે ઇન્કમ જેમ જેમ વધતી જાય એમ, ઉપરનો ગ્રાફ ઇન્કમનો છે, જેમ વધતી જાય એમ કંઈ નીચે જે હેપીનેસ છે વધતી નથી. આફ્ટર સમ ટાઈમ હેપીનેસ લેવલ્સ ઓફ, અને ત્યાર પછી એ ઘટતી જાય છે. એટલે વધારે પૈસાથી વધારે હેપીનેસ આવે વાત ભૂલી જજો. આવું ક્યાંક કહેતો હતો તો વળી એક મોટા ભાઈ ઊભા થયા અને મને કે સુધીરભાઈ મારા ખાતાનો નંબર આ છે, તમે ટ્રાન્સફર કરી દેશો? એટલે મારો કહેવાનો મતલબ એ છે કે મની કેન બ્રિંગ અ સિક્યોરિટી એન્ડ વેલબિંગ, કમ્ફર્ટ એન્ડ સ્ટાન્ડર્ડ ઓફ લિવિંગ, નો ડાઉટ. એજ્યુકેશન પણ આપણા બાળકોને સારું આપી શકીએ, પણ મોર મની કરપ્સ, સક્સેસ કરપ્સ, અને આપણા વધારે પૈસાથી સંબંધો, હેલ્થ, રિલેશનશિપ, મોરાલિટી બધું બગડી શકે. મિત્રો, આ બધા જે તાલીઓ પાડવાના, લોકોના જે પૈસા અને એવોર્ડો માટે આપણે ગડગડાટ કરીએ છીએ એ 1 મિનિટ માટે હોય છે. આપણા માટે શું ઇમ્પોર્ટન્ટ છે? ફોર મી, માય ટીચર્સ, માય ફ્રેન્ડ્સ, માય પેરેન્ટ્સ, ધોઝ હુ હેલ્પ મી, દે આર મોર ઇમ્પોર્ટન્ટ. લોકોના એવોર્ડ ને પૈસાને આપણે શું? એ જ રીતે વોટ એવર યુ ડુ ફોર અધર્સ દે વિલ રિમેમ્બર. હાઉ યુ મેડ ધેમ ફીલ ઇઝ વેરી ઇમ્પોર્ટન્ટ rather than your money or your success. So please remember this. Try to help people. Okay? So one has to choose between success and inner happiness. Success is what? વર્લ્ડના સામ્રાજ્યમાંથી બુદ્ધિ ને સ્માર્ટનેસથી જે લઈ શકો, ગ્રહણ કરો, પૈસા, એવોર્ડ જે બી હોય એ સક્સેસ છે. હેપીનેસ ઇઝ ગિવિંગ સમથિંગ બેક ટુ ધ વર્લ્ડ, એન્ડ ધેટ ઇઝ વોટ વી હેવ ટુ એમ ફોર. મિત્રો, જિંદગીમાં એક રસ્તો એવો પડશે કે જ્યારે આપણે ક્રોસ રોડ પર રહીશું, ત્યારે એક રોડ વધારે ને વધારે સક્સેસ, એવોર્ડ્સ અને મોનિટરીયલ ગેઇન્સ અને વર્લ્ડની વસ્તુ આપશે. The other path, which is less traveled road, will take us to peace and bliss. I think we have to travel that road, and when to do that, that we have to decide. કોઈકની 40 વર્ષની ઉંમરે થાય, કોઈને 50 થાય, કોઈને 80 પણ અક્કલ ના આવે. અને change the drive from sympathetic to parasympathetic. So now આ બધા પછી આપણે નક્કી કરીએ છીએ કે આપણે કેવી રીતે સુખી થવું જોઈએ. તેની ચાવીઓ હું તમને આપી દઉં. આ ચાવીઓ શોધતા મને 22 વર્ષ થયા હતા. એ બધા 22 વર્ષની ચાવીઓ હું તમને આપી દઉં છું. જો ફિઝિકલ, સોશિયલ વગેરે, એમાં 5 એક્ટિવિટીઝ ઓફ હેલ્થ છે, 5 રિલેશનશિપ છે, 5 હોબીઝ છે, 5 મેડિકલ ઇન્ટરવેન્શન છે વગેરે. પહેલાં પહેલું મિત્રો, હેલ્થથી વધારે ઇમ્પોર્ટન્ટ કંઈ જ નથી. બધું હશે પણ જો હેલ્થ સારી નહીં હોય, જાડેજા સાહેબ, તો આપણને કંઈ મજા આવે નહીં. પહેલું સુખ તે જાતે ન રહ્યા. અને પૂરું આરામ કરો, એક્સરસાઇઝ કરો, live elegantly, laugh exhaustingly and love abundantly. બરાબર છે? એક્સરસાઇઝ, રેઝિસ્ટન્સ ટ્રેનિંગ, વેન્ટિંગ. અને આજે રાત્રે હું રોકાઈને અમારા ભાઈબંધો જોડે વેન્ટિંગ, ગપ્પા જ મારવાનો છું, કારણ કે જૂના NHL દિવસો યાદ કરીને મહાવીરસિંહથી મળીને બધા અમે બેસશું, ન્યુરોલિસ્ટો બેસશું અને મજા કરશું. યોગ, મસાજ અને લાફ ફ્રિકવન્ટલી. મસાજ એટલે આપણો ભાઈ, હા, જોજો પાછું થાઈ મસાજની વાત નહીં. મિસઅન્ડરસ્ટેન્ડિંગ તો જોઈએ જ નહીં. સ્માઇલ, કંઈ સમજણ ના પડે તો હસવાનું. પેલો કન્ફ્યુઝ થઈ જાય કે આને શું ખબર પડી કે ના પડી. સ્માઇલ સોલ્વ્સ મેની પ્રોબ્લેમ. અને લાફ ફ્રિકવન્ટલી, બટ નોટ એટ અધર્સ, યોર ઓન સેલ્ફ. કંઈ ના સમજણ પડે તો silence avoids so many problems. Smile solves many problems. Silence avoids it. With all due regards to this gentleman. And love abundantly. Mother Teresaનું આ વાક્ય હૃદયમાં જડી રાખજો. If you spend your life in judging people, then when will you love them? મિત્રો, જિંદગી બહુ ટૂંકી છે. ફલાણા આમ કર્યું ને ઢીકણાએ તેમ કર્યું, એમાં ને એમાં જિંદગી પૂરી કરવી એના કરતાં why not appreciate and love people? And if you love, there is a reward in the rostral brainstem, and you get a beautiful activity in the rostral midbrain which produces profound parasympathetic output. Parasympathetic એટલે low pulse, low blood pressure, low respiration, shanti, sukh and bliss. So that is what is our reward of love and appreciation. There are medical ways also, psychological counseling, mood elevators, and you know, happiness જે માણસ સુખી રહેતો હોય, આનંદમાં રહેતો હોય, એના આ બધા રોગો થાય જ નહીં. સાયકોસોમેટિક જેટલા 80% રોગો છે જે આપણે ટ્રીટ કરીએ છીએ એ બધામાં 80% તો આવા સાયકોસોમેટિક રોગો છે અને લાઇફસ્ટાઇલ ડિસઓર્ડર. એ બધા જે માણસ હેપીનેસને બ્લિસની પ્રેક્ટિસ કરે, they don't get it. And you know, at the other end of the world, we have neurosurgeons who are doing studies and research on deep brain stimulation. Periventricular grey matter ni andar, periaqueduct ni આજુબાજુ, if we are stimulating, we are finding profound feeling of peace. So there are studies like Parkinson માં આપણે ચીપ મૂકીએ છીએ ને, and some people are trying કે ભાઈ આપણે શોર્ટકટ લેવો છે, ભાઈ સુખી જ રહેવું, આનંદમાં જલસા કરવા છે, તો DBS કરાવવું, માત્ર 15 લાખ રૂપિયા થાય છે. અને હવે તો આવી વ્યાપારી બધી વસ્તુઓ ચાલુ થઈ ગઈ છે. ઓક્સિગામ સ્પ્રે કરો અને એકદમ યુ ફીલ કોઝી. એટલે કોઈ માણસ ગુસ્સો કરતો હોય તો માત્ર તમારે નજીક જઈને એનો ગમે તેમ કે નાકમાં 2 સ્પ્રે નાખી દેવા. It will become, you know, you will be surprised. We are laughing, but there are so many research papers getting published on control of our emotions and thoughts. ગુસ્સો, ઈર્ષ્યા, સ્ટ્રેસ, આ બધાને કંટ્રોલ કરવા માટે આ બધા ઓક્સિટોસિન, વેઝોપ્રેસિન, ગાબા વગેરે વગેરેના સ્પ્રે અથવા તો પેચીસ મળવા માંડ્યા છે, which are restricted because of certain legal constraint, but this may be the future of medicine. Then there are genes which I mentioned, and tomorrow you will come to me after your genome project, and you will come and say, Dr. Shah, I have deficiency of these genes. So I will use nanotechnology, robo, and then infuse those genes transvenous or transarterial way into your system, and you will walk out after 24 hours with happy genes. So that is what is likely to be, and I hope it should not be the way the medicine is. So then we talk about 5 important relationships. મિત્રો, હું તમે જે કહેતો હતો ને કે ગમે એટલું કમાઓ પણ તમે આખો દિવસ લોકોને ખખડાવ કરો, ઘરમાં બી મગજ ખરાબ રાખો, એવા જીવનનો અર્થ શું છે? સો મેરિડ લાઈફ, ચિલ્ડ્રન, ઇનલોઝ, પેરેન્ટ્સ, ફ્રેન્ડ્સ એન્ડ પ્રોફેશનલ પ્લેસીસ, આ 5 જગ્યાએ આપણે રિલેશન મેન્ટેન કરવાના છે. એમાં હેપી મેરિડ લાઈફ, ઓક્સિમોરોન, હેપી એન્ડ મેરિડ લાઈફ, I don't know. પણ મેરેજની ડેફિનેશન વાંચવા જેવી છે. ઇટ્સ અ વે થ્રુ વિચ 2 people join together to solve the problems they never had before. બે એકલા હતા ત્યારે મારા બેટા મજા કરતા હતા, ભેગા થયા અને પ્રોબ્લેમ્સ ચાલુ કરે અને પછી એને સોલ્વ કરે. દેટ ઇઝ મેરેજ. અને યુ નો ગૂગલ બહુ જ ભટકાવે છે. અમને બી આજે અડધો કલાક અમારો રસ્તામાં બગાડ્યો ગૂગલે આ જગ્યા શોધવામાં. એટલે ગૂગલને એકવાર પૂછ્યું હતું કે ભાઈ મારા ઘરવાળાને મારે ખુશ રાખવા શું કરવું જોઈએ, એ બિચારો માથું ખજવાડતો. પણ after 15 years of struggle, I got the answer from my wife herself. She told that women want to be understood, loved, cared, validated, accepted and freedom. If you give this, the whole world is yours. એટલે વાહ, અને મેં કરવા માંડ્યું અને મને જલસો થઈ ગયો. પછી એણે મને પૂછ્યું કે તમારે શું જોઈએ? એટલે અહીંયા જે બહેનો બેઠા છે એમને આ એક ટીપ આપું છું કે મહેરબાની કરીને એમના ઘરવાળાને એમને છોડી મૂકો. અને બાળકો માટે તો ભાઈ તમે પૈસા ના આપો, આપવા થોડા ઘણા ઠીક છે વસ્તુ માટે, પણ એજ્યુકેશન આપો, ટાઈમ આપો તમારો, ક્વોલિટી ટાઈમ, કલ્ચર, એજ્યુકેશન, વિઝડમ એન્ડ આર્ટ. સો દેટ ઇઝ, અને ટેક કેર ઓફ યોર પેરેન્ટ્સ એન્ડ ઇન-લોઝ એન્ડ સ્પેન્ડ ટાઈમ વિથ ચિલ્ડ્રન એન્ડ યુ શુડ હેવ ગુડ ફ્રેન્ડ્સ. આઈ એમ સો લકી that my 5 relations are absolutely strong, including friends and family. And that is a very important aspect. So Harvard study had mentioned that the longest living people have the best of relationship in their life. Then you should learn 5 activities of 5 types of hobbies, either music, dance, art, creativity, some kind of, or traveling, or reading, or gardening, or keeping a pet, or grooming and photography. જે ડૉક્ટરની મેં મોટાભાગના ડૉક્ટરને જોયું, they have some or other type of activity and creativity, and that's what make them happy. અહીંયા મારો ભાઈબંધ હિરેન બેઠો છે, એ આખા દુનિયાના લોક્સ એના ઘરે ભેગા કરીને ઉપર લોક મારીને બેઠા છે. આખું વર્લ્ડ એને ત્યાં જોવા આવે છે બધું, એટલું સુંદર. એટલે these are the things which give you a lot of joy. So reading is, a library is a hospital for the mind. We read to know what we are not alone. So મિત્રો, મારે ત્યાં 10,000 પુસ્તકની, નોન મેડિકલ પુસ્તકની લાઇબ્રેરી છે, અને I enjoy reading. So reading, music is the medicine of the mind. એટલે મ્યુઝિક તો શીખવું જ જોઈએ. અને ગાના આય યા ના આય, ગાના ચાહીએ. એવી રીતે પેઇન્ટિંગ, ફોટોગ્રાફી. Then 5 virtues. There are 5 virtues which make us happy. જે તમને યાદ આવ્યું, એરિસ્ટોટલે કહ્યું ને કે 5 સદ્ગુણ જોઈએ. Gratitude, appreciation, forgiveness, kindness and acceptance. મિત્રો, જે કોઈ માણસે તમને થોડી પણ મદદ કરી હોય એનો તમે આભાર માનો. રોજ સવારથી સાંજ તમે 2-5 માણસોનો સાચા હૃદયથી આભાર માનો. 5 માણસને તમે એપ્રિશિએટ કરો એના સાચા અને સારા કામ માટે, ખોટા મસ્કા નહીં મારવાના. ફર્ગિવનેસ, જેને બી તમને બગાડ્યું એની જોડે હિસાબ કિતાબ ચૂકતે કરવા, માફી આપી દો કાં તો માફી માગી લો. અને કંઈ નહીં તો 5 માણસને તમે નાની નાની મદદ કરો, કોઈને ખાવાનું આપો, કોઈને રસ્તો ક્રોસ કરાવો, કોઈની ફી ઓછી લો, કંઈક જે તમને ઠીક લાગે. અને જે તમારાથી ચેન્જ ના થઈ શકે, ઓટીમાં પેશન્ટને કાર્ડિયાક એરેસ્ટથી ગુજરી જાય, એમાં આપણે શું કરી શકીએ ભાઈ? બધાએ ફિટનેસ આપીને પતી ગયો. પણ એ દેટ ઇઝ વોટ બુદ્ધિપૂર્વક એને હાઉ ટુ હેન્ડલ જે આ લોકોએ શીખવાડ્યું, બહુ સરસ કરી વાતો બધી, એ આપણે એક્સેપ્ટ કરવું પડે. અને ગ્રેટિટ્યૂડ અને એપ્રિસિએશન જેવો કોઈ મહાન વર્ચ્યુ નથી. ટેક ઇટ ફ્રોમ મી. જે વખતથી 22 વર્ષથી મેં લોકોને સાચા દિલથી આભાર માનવાનું અને એપ્રિશિએટ કરવાનું શરૂ કર્યું, ત્યારથી મારી જિંદગીમાં એબન્ડન્સ આવી ગયું. અને યુનિવર્સ હેઝ ગિવન મી મલ્ટિપલ ટાઈમ બેક एंड फॉरगिव. गालिब का एक शेर है, गालिब हमने जिंदगी को यूं ही आसान कर दिया. गालिब हमने जिंदगी को यूं ही आसान कर दिया, बहुतों को माफ़ कर दिया और बाकी से जाके माफ़ी मांग ली. खत्म. એટલે રોજ રાત પડે હિસાબ ક્લિયર કરીને સૂઈ જવાનું અને હેલ્પ અધર્સ, એક્સેપ્ટિંગ. સો મેથેમેટિક્સ ઓફ હેપીનેસ ઇઝ ડિફરન્ટ. તમે જો શેર કરશો તો ડબલ થશે, ડિવાઈડ નહીં થાય, ડબલ થશે. અને તમારી ઈચ્છાઓ કરતાં તમારી પાસે છે એના કરતાં તમારી ઈચ્છાઓ વધારે હશે તો હેપીનેસ ડિવાઈડ થઈ જશે. તમારે 1 ગાડી હોય ને 2 ગાડી જોઈતી હોય તો તમારી હેપીનેસ અડધી થઈ જશે. અને રિયાલિટી અને એક્સપેક્ટેશન મેચ નહીં થાય તો પણ પ્રોબ્લેમ થશે. એટલે મિત્રો એમ ધ્યાન રાખજો. હેપીનેસ ઇઝ એકચ્યુઅલી અ સ્ટેટ ઓફ માઇન્ડ. It is not something that happens that money or power can command. આ તો અમૂલ્ય વસ્તુ છે, that cannot be bought from outside. ફિઝિકલ વર્લ્ડમાં આપણે કંઈ જોઈતું હોય ને તો વી ગો, ભાઈ મારે પૈસા આપીને કે ગોલ્ડ આપીને કે કોઈ વસ્તુના બદલામાં હું બીજી વસ્તુ લઈ શકું, કોઈ પણ વસ્તુ ખરીદવી હોય. પણ આ ઇનર વર્લ્ડ છે જેને ક્વોન્ટમ વર્લ્ડ કહેવાય. ક્વોન્ટમ વર્લ્ડ એટલે સ્પિરિચ્યુઅલ વર્લ્ડ છે. એમાં મારે જે જોઈએ ને આ બધી વસ્તુઓ, હેપીનેસ, પીસ, આ બધી ક્વોન્ટમ વર્લ્ડમાં રહે. એટલે એ મારે જે જોઈતું હોય ને એ જ મારે આપવું પડે. ઇફ આઈ વોન્ટ હેપીનેસ, આઈ હેવ ટુ ગીવ યુ હેપીનેસ. ઇફ આઈ વોન્ટ પીસ, આઈ હેવ ટુ ગીવ યુ પીસ. ઇફ આઈ વોન્ટ રિસ્પેક્ટ, આઈ હેવ ટુ ગીવ યુ રિસ્પેક્ટ. અને જો હું કોઈને દુઃખ આપું તો મને દુઃખ જ મળવાનું, એ ધ્યાન રાખજો. અને બીજો રૂલ છે એમાં ક્વોન્ટમનો કે તમે જે આપશો એનાથી અનેક ગણું પાછું આવશે. તમે 10 યુનિટ હેપીનેસ આપી હશે તો 1000 યુનિટ આવશે, અને કોઈને ત્રાસ આપ્યો હશે તો એનાથી 1000 ગણો ત્રાસ તમને પાછો આવશે. અને ત્રીજો નિયમ એ છે કે મેં સુખ XYZ આપ્યું હશે તો ત્યાંથી નહીં આવે, મારું સુખ અહીંયાથી આવશે. આ સર્કલ ઓફ લાઈફ છે. આ 3 નિયમો એ બહુ જ ઇમ્પોર્ટન્ટ નિયમો છે. એ આપણે જાણતા નથી એટલે જ બધી ગડબડ થાય કે મેં ફલાણા માટે આટલું બધું કર્યું ને એણે મને આવું કર્યું ને પછી આપણી ગાંઠો વાળે છે. એવું નથી. ક્વોન્ટમ વર્લ્ડ, લુક એટ ધ વર્લ્ડ ઇન અ ડિફરન્ટ વે. ઠીક છે? યસ, એટલે છેલ્લે આપણે જે વાત કરવાની છે 5 મેન્ટલ પ્રોસેસની, જેમાં આપણે બહુ એટેચમેન્ટ બહુ રાખવાના નહીં, બહુ આપણા થોટ્સને ક્લેરિફાય કરવાના, શુદ્ધ કરવાના, આપણી ડિઝાયર્સ ને એમ્બિશન, ઈચ્છાઓ ઓછી કરવાની, આપણી ઇમોશન પોઝિટિવ કરવાની, અને ઈગો આપણે ઘટાડી દેવાનો, એટીટ્યૂડ સુધારવાનો. એના માટે ઘણું કહી શકાય કે ઈચ્છાઓ રહી જાય અને શ્વાસ ખૂટી જાય તેને મૃત્યુ કહેવાય. હું મરી જઉં ત્યાં સુધી મારી ઘણી ઈચ્છાઓ બાકી રહી ગઈ તો ખરેખર મૃત્યુ જ કહેવાય. પણ હું જીવતે જીવતે મારી બધી ઈચ્છાઓ પૂરી થઈ ગઈ હોય એ જીવતા મોક્ષ થયો કહેવાય. એટલે આપણે બહુ જ ઓછી એમ્બિશન્સ રાખવાની, આપણી રિયાલિટીને મેચ થાય રાખવાની, અને સ્ટોપ કમ્પેરિંગ, સ્ટોપ એક્સપેક્ટિંગ, સ્ટોપ ક્રિટિસાઇઝિંગ, but start sharing, helping and loving. Give and forgive, count blessing and enjoy every moment. And the last 2 minutes is on spiritual aspect. મિત્રો, રિલિજનને બહુ લોકો ગેરસમજ કરે છે. આજે બહાર સંપ્રદાય છે, રિલિજન નથી. રિલિજન તો એ આપણે જે સત્ય, અહિંસા, અસ્તેય, બ્રહ્મચર્ય, અપરિગ્રહ, એ જે નિયમો અને નીતિ છે એ નિયમ એ આપણા એ છે. ઇથિક્સ એ આપણો રિલિજન છે. અને જેના સ્પિરિચ્યુઅલ કમિટમેન્ટ્સ વધારે છે એ લોકોનું હેપીનેસ લેવલ બહુ હાઈ છે, એવા પણ સ્ટડી થયેલા છે. અને આ 5 પ્રેક્ટિસીસ છે જે આપણે ડૉક્ટર તરીકે વોટ્સએપ અથવા બીજામાંથી સમય કાઢીને તો થોડુંક સ્વાધ્યાય, એટલે આપણી જે પણ હોલી બુક હોય, કોઈ ગીતા વાંચે, કોઈ ભાગવત વાંચે, કોઈ આગમ વાંચે, કોઈ ત્રિપિટક વાંચે, થોડું સત્સંગ કરે, ચેન્ટિંગ કરે, ડિવોશન કરે, અને કર્મયોગ કે જ્ઞાનયોગ, ભક્તિયોગની બરાબર ડિટેલ સમજીને એને ફોલો કરે, અને નાનું મોટું કોઈ તપશ્ચર્યા કરે અને ધ્યાન કરે તો એનું જીવન સુખી થાય. પ્રેયર વખતનો આ સ્કેન અમે કર્યો હતો, એમાં બ્રેનની લિમ્બિક સિસ્ટમમાં એટલું બધું એડવાન્સ બ્લડ ફ્લો થાય. જો સાચી પ્રેયર કરવામાં આવે તો પણ માણસને સખત પેરાસિમ્પેથેટિક ઓવરફ્લો થાય, પણ સાચી પ્રેયર. ભગવાન તું આમ કરે તો 2 શ્રીફળ વધેરીશ એ નહીં, પણ હું આખા વિશ્વનું કલ્યાણ થાય એવી પ્રાર્થના કરવાની હોય છે. અને મેડિટેશન આપણે સૌએ થોડું ઘણું શીખવું જોઈએ. અને આખી વાતનો એન્ડ હું એક જ સ્લાઇડથી કરીશ હવે, એના માટે મને 1 સેકન્ડનો ટાઈમ આપજો. સોરી. આ ડૉક્ટર એન્ડ્રુ ન્યુબર્ગે કરેલો FMRI છે જે બતાવે છે કે મેડિટેશનની ડેપ્થમાં આપણો જે પ્રીફ્રન્ટલ લોબ છે, જેને લીધે આપણે હ્યુમન બિંગ તરીકે આટલા બધા વિશ્વમાં રાજ કરીએ છીએ, જ્યાં આપણી ઇન્ટેલિજન્સ, આપણી પ્રાયોરિટાઇઝેશન, એક્ઝિક્યુટિવ ફંક્શન, થોટ, કોમ્યુનિકેશન, આ બધું જ્યાં છે એ ડ્યુરિંગ મેડિટેશન એ એરિયામાં સખત બ્લડ ફ્લો 30% વધારે આવે છે. એટલે આપણી પ્રજ્ઞાનો વિકાસ ધ્યાન દ્વારા થાય છે, એટલું યાદ રાખજો. અને સાથે બીજી વસ્તુ એમણે શોધી કે લેફ્ટ પેરાઇટલ એરિયામાં અહીંયા મેડિટેશનમાં બ્લડ ફ્લો શન્ટ થાય છે. એટલે કે ડ્યુરિંગ મેડિટેશન તમારી ઈચ્છા, અભિમાન, ખરાબ વૃત્તિઓ, નેગેટિવ ઇમોશન્સ, આ બધું એમાં ડાઉન થાય. એ એરિયા છે લેફ્ટ પેરાઇટલ ઓક્સિપિટલ એરિયા. ઇઝ કોલ્ડ પોસ્ટિયર સુપિરિયર પેરાઇટલ લોબ્યુલ, PSPL. ને ત્યાં આગળ આ બધી શોધો થયા પછી આખું પશ્ચિમી વર્લ્ડ, વેસ્ટર્ન વર્લ્ડ ઇઝ નાઉ ફોલોઈંગ મેડિટેશન, એન્ડ વી who had invented real meditation, we have forgotten. So friends, I am here to remind you to do these spiritual practices including meditation little daily, learn that, It will improve your attitude. You can take a photograph of this slide because I don't have time to read. Friends, pain is inevitable, but the suffering is optional. અને આપણે બધાને જન્મ્યા ત્યારથી દુઃખ તો છે જ, પણ આ બધા રસ્તા મેં આપણે બતાવ્યા, એ રસ્તે જો આપણે જઈશું તો ધીરે ધીરે દુઃખમાંથી મુક્તિ આવશે અને ડૉક્ટર હોવાની સાથે સારા કામની સાથે પણ આપણે સુખી રહી શકીશું અને આપણા જીવનને બેલેન્સ કરી શકીશું. એટલે this is the nutshell of my whole lecture, how we have, this is the roadmap how we can live. And this is very simple, 9 નાની વસ્તુઓ જે appreciate, gratitude and all that, and reading and hobbies and relationship, etc., which you can all do. Happiness is not outside, it is inside you. Thank you very much.
Thank you, sir. You had given a beautiful message to our doctor that heal thyself, doctor, before healing your patient. Thank you.
મિત્રો, ડૉક્ટર સુધીરભાઈ એક વાક્ય કીધું કે there are two kinds of people. One is a happy people and other is the doctors. આજના આ પ્રવચન પછી એટલીસ્ટ આપણે આ મેળું સુધીરભાઈનું ભાંગવું જ પડશે. સુધીરભાઈ એના વિષયના એટલા બધા મોટા નિષ્ણાંત છે કે હું જ્યારે 1985-90માં મેડિકલ કોલેજમાં હતો ત્યારથી ન્યુરો ફિઝિશિયન તરીકે ગુજરાતમાં એક જ નામ ઉપસતું હતું. તો એમને એટલા બધા વિષયો ઉપર એ બોલી શકતા હતા, પણ જે આજે એને ટોપિક પસંદ કર્યો છે એના માટે હું એમને ધન્યવાદ આપું છું. જીમાકોનની સમગ્ર ટીમને ધન્યવાદ આપું છું કે તમામ લેક્ચરોનું સ્તર અને સ્પીકર અને જે પસંદગી છે એના માટે ખૂબ ખૂબ ધન્યવાદ મહાવીરસિંહ અને તમામ ટીમ મેમ્બરોને. અને બીજા ભરતભાઈ પણ મારી સાથે છે, 2 ભરત છે આજે ચેરપર્સનમાં, અને વી વુડ ડેફિનેટલી લાઇક ટુ ફેલિસિટેટ ડૉક્ટર સુધીરભાઈ.
બસ મારું એક જ વિનંતી છે આપ સૌને, આમાંથી જે કંઈ પણ આપને અનુકૂળ હોય, જે થઈ શકે બધું કરજો અને આપણી ડૉક્ટર કમ્યુનિટી વધારે વધારે સુખી થાય, એક જ માત્ર મારો ઇન્ટેન્શન છે અને આપ જરૂર સુખી થાઓ એવી ભગવાનને પ્રાર્થના. થેન્ક યુ.
I request chairperson to honor Sudhir Bhai for an excellent lecture, a very a happiness before lunch on empty stomach, but the stomachs are full with happiness. Now I request Dr. Boderia sir to honor 2 chairpersons.
Sir, one request is from audience that with due permission from yours, can we share PDF of your presentation to the audience?
It is meant for happiness of everybody, so let it be shared.
Thank you very much.
Actually, it's on my website also.
So thank you very much, sir.
After lunch, the program will start as per schedule.
Good afternoon all. We'll be inviting Dr. Parin Patel. He has done fellowship in head and neck oncology and he is working as consultant head and neck oncology services at HCG Ahmedabad. In the scientific and research paper and award section, he has done various researches in the art of surgery and has also presented in Indian Journal of Surgical Oncology as well as Indian Journal of Otolaryngology and Head and Neck Surgery in 2018. And there is also research on squamous cell carcinoma in gingivo-buccal complex that is published in Journal of Head and Neck Physician and Surgeons. And right now, and then oncological outcome following 3-drug neoadjuvant chemotherapy in selected subset of head and neck patients with supra-notched infratemporal fossa extension.
Good afternoon, everyone. Thank you, chairs. Thank you, seniors and my dear colleagues. And thank you, GIMACOM team, for inviting me to this GIMACOM 2023. I would deliver a lecture on the recent advances in head and neck cancer that we commonly use in our day-to-day practices. Okay, so I will be discussing the these 8 topics: robotic surgery, laser in the head and neck surgery, now monitoring intraoperative, endoscopic pelvis surgery, microwave ablation of thyroid surgery, microvascular reconstruction, tomotherapy, and the neoadjuvant chemotherapy. It is very difficult post-lunch to keep you awake, but I will try as much as possible. After the enlightening lecture by Sudhir sir, this robotic surgery was first granted the permission in 2003 for the genitourinary system as well as for the GI system. But for the head and neck, it has been approved in 2009 by US FDA. So there are the different robotic systems that are available in the market: Da Vinci system, Medtronic system, then the Navio from Smith and Nephew, Mako from Stryker, Mantra. Mantra is a Delhi-based, local, homemade robotic system. So overall, if you see, there are 66 centers in India that are using this robotic system. And we have started our robotic program in 2016, and so far we have done 1,600 robotic surgery. And out of that, head and neck comprise very small chunk, but still the major, almost 100 robotic surgery we have done since that. So these are the, early in the morning, Dr. Mahesh Patel showed that these are the different parts of the robotic system. First one is a endocart, the middle one is a patient console, and the last one is a surgeon's console. So what are the advantages of the robotic surgery? It has a 7 degree of the freedom of rotation. And along with that, the tip of that robotic arm rotates around 360 degree. So this is an advantage, and we can reach to the different nooks and corner of a cavity. It can be attached with the image guided system, so which will provide a better stereotactic orientation of surgical instruments. The tip of the surgical instrument can be arranged properly and reach accurately at the precise location. For the surgeons, it provides the binocular 3D vision. And obviously, as discussed in the morning, the telepresence and the telemonitoring. Telepresence means you can operate from some distant source, and the telemonitoring, you can monitor your subordinates or other surgeon how he is doing. This is all possible with the robotic system. The only disadvantage that we have is the expense. It costs around some 15 to 60 CR system. The size is also a problem. The robotic system that it occupies the large amount of the OT complexes. So we hope that in near future we can get a single port robotic system with smaller instruments. And there is a loss of tactile perceptions also. It is means the tactile perception that we have in the routine surgery, open surgery, it is difficult to have in the robotic system. But another most important advantage is it filters the intentional tremors. So this is an animation of that Da Vinci robotic system. It will hardly take 1 to 1.5 minutes. So in head and neck, what are the parts, or where the parts that where we use the robotic system is the base of the tongue, tonsil, laryngeal and hypopharyngeal early malignancies. We can also perform a neck dissection and thyroid surgery via the robotic system. So it is a small demonstration of the robotic base of tongue resection. It is generally very difficult to reach the base of tongue near to the vallecula and the epiglottis with our naked eye as well as with all other instruments. But the robotic hand can reach there, and we provide a precise cutting. Separating a specimen close to the epiglottis, and we will send it for frozen examination. This area we will keep raw as a very small defect is there. We will do a tracheostomy depending on the defect that is created. If the larger defect is there, then we will definitely do for a tracheostomy prophylactic. The advantage is a CO2 laser, but CO2 laser is available since very long, but this ultra pulse or super pulse laser of luminous system is a highly accurate, it will produce very less lateral thermal damage, and it is also minimal invasive. The different shapes of the laser can be created, like a thin blade or the dot, which will provide accurate resection. This is the position of the patient who operates the laryngeal malignancy with the help of that CO2 laser. So these are the all indications where we use this this laryngeal CO2 laser, that is early glottic cancer, early supraglottic cancer, T1, T2. Even for early pharyngeal and hypopharyngeal cancers, we are using this transoral laser surgery. The advantages of this is a minimal invasive. And there are the various articles which will be discussed later on. Okay, suppose if we do a early stage laryngeal malignancy resection with the laser, we won't require the radiation therapy. So we can avoid the radiation therapy in early stage laryngeal cancer. So we can avoid the side effect of the radiation. This is a small video of that AccuPulse CO2 laser, which will provide you a better view of that, how sharp and accurate it is. This is a very precise cutting of a vocal cord lesion. This is a band or the fiber optic cable that is available with a modern laser. So we can go very close to that tumor and resect it for the laryngeal malignancies. We can burn the leukoplakic lesion without much lateral damage. So these are all the few articles, one of the articles from that China, which suggests that which has compared the laser surgery versus the radiation in early stage malignancy of larynx, T1, T2, N0. And it has been found that the survival, DFS as well as oral survival, are comparable and similar in both the setup. This is another article by Higgins, which also suggests that the T1, T2 laryngeal cancers have a similar survival compared to the radiation therapy. So in this case, we can avoid the long-term side effect of the radiation. Another advantage of the laser surgery, suppose if there is a recurrence after the laser surgery, we can redo the laser. But after the radiation therapy, suppose if you have given a radiation therapy and there is a recurrence, now in that case, we have to completely do a total laryngectomy. This is another recent advantage, intraoperative nerve monitoring. Initially used for the neurosurgery, but recently it has been started for using for various head and neck surgery like thyroid, parathyroid, parotid surgery. The advantage is it helps in identifying the nerve early so that it prevents the damage to the nerve. So basically it will provide it works on the mechanism of the electrophysiologically, that electroencephalogram or electromyography, which will stimulate the nerve and it will produce the impulse on the recorder. This is a video which will demonstrate whenever the probe is being touched to the facial nerve, it will generate it will pass the current and it will generate the impulse which will lead to the contraction of a facial muscles. So we are touching a facial nerve with the help of the probe. You can see the contraction of the muscle, and this same has been recorded, impulse has been recorded on the monitor. So this will help in the identification of that facial nerve or the recurrent laryngeal nerve during thyroid surgery in the early stage. These are useful during the recurrent cases or the revision cases. But if you want to use for recurrent cases or the revision cases, we have to keep using during the routine normal cases. Otherwise, we won't develop that technique or habit to find the nerve easily. So this is an article from the Tata, which says seeing is not believing. So suppose if you see an intact nerve anatomically, that does not mean that the nerve is functional in normal. So they have proved that even though the nerve is anatomically intact, but if there is no electrophysiological current available or the non-perception of any voltage, we can say that the nerve is not functioning. So this has also become one of the useful tool for the medical legal purposes, which shows that even before the surgery, the nerve was not functioning, and after the surgery, we have monitored the impulses and it says that the nerve is still not functioning. Another the advantage is endoscopic skull-based surgery. The endoscopic skull-based surgery is there is a tremendous advantage in the advance in the last decade. It has become one of the standard of the care for the nasal malignancy, most of the nasal malignancies nowadays. Previously, we used to open it and then do the resection, but nowadays, hardly in a few cases, we open it and do the resection. Most of the cases, we resect endoscopically. It requires the dedicated training for the endoscopic skull-based surgery and also require good instrumentation and the endocard. So in what scenario we can use it for the nasal malignancy, pituitary tumor, clival tumors, intracranial meningiomas, CSF closure. So whenever we have to cross the dura, we always use the, always function with our neurosurgeon, and it is a team approach. So these are the setup. This is a setup that we use for the endoscopic surgery. One is a main monitor, other one is a slave monitor, which will be used for our assistant surgeon who will be looking directly into the slave monitor. The advantages is a better cosmesis, no external scar, better visualization. It provides a magnified vision of the vessels and the nerve, and the combined endoscopic and open craniofacial surgery can be done without the facial incision. In few of the cases, we have also done the endoscopic craniectomy, that is without opening giving the bifrontal craniotomy. We were able to resect the cranium from endoscopically with the help of a neurosurgeon. So this is also one of the advance that we are seeing in our head and neck surgery. Only disadvantage with this is that it has a steep learning curve. The instrument that is required are costly, and the dedicated training is required from a tertiary center. There was a question, okay, sir, in endoscopic you are doing the surgery by sequential resection. That is a piece by piece sequential resection. So how come it has the same survival or disease-free survival compared to the open surgery? But this is an article of 2011 which shows that even with the endoscopic surgery we are able to achieve the similar survival as compared to the open surgical method. So in the last decade, the endoscopic surgery as well as the technique and technology has advances. So more and more research articles are coming up which shows that the endoscopic surgery has become a standard of the care for the nasal malignancy unless and until it is contraindicated. This is one of the most recent advances, and it's microwave ablation of thyroid nodules. It is a non-surgical treatment of thyroid nodules. It works on the principle heat is generated by the microwave energy, and that heat will damage or destroy the tumor tissues, followed by a necrosis, and ultimately your body immune system will degrade it. So it is used for a benign thyroid nodules. Size can be ranged from the 1 to 5 centimeter, depend on the experience of a surgeon and interventional radiologist. And it can also be used for the hyperfunctioning nodules. So brief information about that.
What is the advantages of ablation? Ablation is minimally invasive procedure. The wound is only the size of the needle tip. No scar. Short operation time. Fast recovery.
Okay. So next slide. Yeah. So basically the advantages are it can be done under local anesthesia, under USG guidance. So it requires the interventional radiologist with a surgeon. It is a day care procedure. Mostly the patient has been discharged in 2 to 3 hours. It has a very minimal side effect like recurrent lung injury or hypocalcemia, and bleeding is very, very minimal. And even we can do a corrective recurrent or the redo interventional ablation if the size does not reduces. The cost is very less compared to a surgical intervention. It is a scarless procedure, and the thyroid function is preserved. So the most of the cases that we have done is on the benign thyroid nodules up to the size of 3 centimeter. But the Chinese people are doing this up to the size of 5 to 6 centimeter. And the most important is a disadvantage. The only thing is that the reduction of size of the nodule will take 3 to 12 months to reduce. And suppose if there is a more than 50% reduction in the size of the nodule over the period of 12 months, it is considered to be a good result. Generally, it is not suitable for a large or compressive thyroid nodules. In that case, you will definitely require the surgery. For the malignancy, still we haven't used, and there is a very less evidence which suggests to use for the malignancy. But we are waiting for evidence, or we want to generate the evidence whether we can use for the early malignancy or not. The local pain, earache, and hoarseness are the very, very, very rare side effects. So I would suggest over the period of the time in next 5 years, the surgery for the thyroid surgery, that is hemithyroidectomy for benign nodules, will almost disappear because of this radioactive ablation, microwave ablation. This is a long-term outcome of a Chinese paper which shows that they have followed their patient for 48 months, and it shows there is a reduction in the size in almost 96 to 97 of the percentage of the patient. And most of the patient have the cosmetic problem for which they underwent the surgery. So as you compare on the left side, the size of the swelling is visible, and on the right side after the ablation, it almost disappears. So over the period of next 5 years, I would say surgery for benign thyroid nodules is going to disappear, and this will become a mainstay of the treatment for benign thyroid nodule. So you should have a good interventional radiologist in your team to perform this procedure along with you. Another recent advance is microvascular. This is not a recent advantage, but over the period of the time, we have improved expand our limit and horizon. So it is basically a free microvascular tissue transfer with a vascular, that is arterial and venous anastomosis between the donor and the recipient vessels. The shape can be contoured according to the defect size, and it can be a soft tissue or it can be soft tissue plus bony microvascular transfer. At our institution, the success rate of this microvascular transfer is 95%. In 5%, we have to do a redo surgery, or we have to discard the flap and do another surgery. So in last 7 years, we have performed almost more than 2,000 microvascular flaps. Obviously, for microvascular, you require dedicated, good microvascular plastic surgeon to achieve this 95% success rate. Otherwise, it is not possible. The advantage of the microvascular surgery is better contouring according to the defect size, so that it produces a better cosmesis. We'll show the photo. Radial artery forearm flap is excellent for a after tongue resection because it provides a good mobility of the remnant tongue. Also, the other advantage is less donor side morbidity, avoidance of swelling in the neck, and the negligible shoulder defect. The disadvantage, it is a time consuming, add to the expense because it requires a lot of consumables, as well as the time is increased, OT time increase, and require the close monitoring for 5 to 7 days. So this is an example of a tongue defect, lateral margin tongue, SCC, after the resection. and this has been reconstructed with the help of the free radial artery microvascular flap. So the mobility of the remnant tongue has been preserved because this flap is highly pliable. This bilateral cheek defect, bilobe cheek defect, reconstructed with the help of the microvascular anterolateral thigh flap. This is a similar but small defect, which is also reconstructed with the help of the small, very small perforator based microvascular ALT flap. And if you see the cosmesis, it's almost comparable to the opposite side. So if we use the pectoralis major for this defect, it may create a unnecessary excessive bulge in the face as well as in the neck. So to avoid that, this has become a workhorse for our reconstruction. This is a free microvascular fibular flap in which there is a through and through defect from one angle of mandible to the opposite angle, which we have reconstructed with the help of that fibula bone, and you can see the OPG post reconstruction, where we have reconstructed the fibula, that is mandible, with the help of fibula from one angle of the this mandible to the opposite angle of the mandible. So that will provide a good cosmetic result as well as a functional result also. Now jumping to the tomotherapy, this is a recent advantage, and I hope that if any mistake is done, the Dr. Duvida will correct me. Tomotherapy basically works on the linear accelerator. This is a conventional field, and this one is a IMRT field, which will provide a precise radiation to the particular organ without causing any side effect to the surrounding area. So basically, tomotherapy works on the principle of the CT scan. It provides the radiation in a sliced manner. It provides the radiation in a sliced manner to the particular target without exposing to the other normal or surrounding organs. So the advantage is it provides a good normal tissue sparing, more conformal and more accurate, and can be used for any tumor in the body. The disadvantage is little costly compared to the other modalities, because it is also time consuming. It requires a lot of calibration by technicians as well as a radiologist as well as a radiation therapist. So this is a domain of the medical oncologist, but I would like to describe few points regarding the neoadjuvant chemotherapy, because this neoadjuvant chemotherapy was invented in the late 1970s or some 80s, but still it has nowadays becoming a workhorse for various head and neck malignancies. Neoadjuvant chemotherapy means the chemotherapy that we provide before the surgery. And what are the indications where we provide a neoadjuvant chemotherapy? The tumor is unresectable. In this case, we want to shrink the tumor and then send it the tumor for a radiation therapy. In that case, it is useful. Second indication is borderline operable. If the tumor is borderline operable, we are not able to get the margins, then give him or her a neoadjuvant chemotherapy, which will shrink the tumor, make it operable, and then resect. This is possible in 70 to 80% of the cases. Third indication is organ preservation. Suppose if you want to preserve a larynx or the mandible, then we give a chemotherapy to the patient, 2 to 3 cycles of the chemotherapy, NSCT, that will reduce the bulk of the tumor. If suppose the bulk of the laryngeal tumor is reduced, then we can definitely preserve the larynx with the help of the radiation and chemotherapy. We won't require the surgery. And by doing that, we are able to save 65 to 70% of the larynx in our routine day-to-day practice. And certain biologies are there, like esophageal neuroblastoma or SNTCA, sinonasal teratocarcinoma, where the this neoadjuvant chemotherapy is used because of the highly chemosensitive tumor. These are the standard regimens that we use in our practice. TPF means Taxanes, that is a docetaxel, platinum, and the 5-FU, which is a standard treatment line. If suppose the patient is sensitive to 5-FU or highly 5-FU produce excessive side effect, then we can use the TPE, that is Erbitux, that is a target therapy. Sometimes patient may have the recurrence, and in that case, we may have to use another modality of the treatment. At that time, we can combine with immunotherapy. But it is to be decided by a medical oncologist. There are the various evidence, that is level, not level 1 and 2, but up to the level 3, there are the evidence that chemotherapy, neoadjuvant chemotherapy definitely improve the disease-free survival. This is an article from the, okay. This is an article from the Veterans Affairs, early conducted in 1990s, which shows that if we give the neoadjuvant chemotherapy in stage 3 and stage 4 of the larynx, we can preserve the larynx in the 65 to 70% of the cases. So this is a landmark article which we are still following. Various articles are there. This article is from our institution. We have used the neoadjuvant chemotherapy in the supranotch infratemporal fossa disease, and after 3 cycles, we operate that patients, and overall disease-free survival we found it's around 69 to 70%. So when we compare our data with other Liao's and other articles where they have operated the upfront tumor of the supranotch ITF, and their survival was around 48%. So I must say that because of that neoadjuvant chemotherapy, the 3-year survival is around 70%, that we have improved it. Thank you so much. This is our team of the consultant at Astha Oncology Associate at SCG Cancer Center, Ahmedabad. And thank you so much. Any questions?
Sir, question. As you describe all the modalities and advancement in the treatment of malignancy, day by day the incidence of cancers are increasing, and unfortunately Gujarat is one of the states. Main constraint is cost factors.
Right.
You mentioned tomotherapy and everything.
Right.
So how you see the futures of all this affordability of all kind of treatment and the cost?
Right.
That is important factors for the patient.
That is the most important factor. So for the tomotherapy, the cost generally increased by the 1 lakh compared to the other linear accelerator. But if you see the survival as well as the other benefits and side effects, they are almost comparable to the IMRT as compared to the tomotherapy. But over the period of the time, I suggest a company may reduce the cost and it may become available to all the patient with the same cost benefit. And in the robotic system, there is a constraint, as Mahesh Bhai already mentioned in the morning, there is a increase of around 1 lakh rupees when we do robotic surgery and non-robotic surgery. This is because of the instrumentation that we have to use for the robotic system, because most of them are disposable instrument and we can't use more than one time. So we hope that in near future we will be able to get that instrument that will provide us we can use for more times, multiple times, and we can reduce the cost of the robotic system. Thank you so much.
I request the chairpersons to felicitate Dr. Pareen.
Thank you for your informative lectures. Thank you.
I request Dr. Krishna Ben Lakhani to felicitate chairpersons.
I think Dr. Pareen has done the job of keeping us all awake after the post-lunch session really well. So a bigger round of applause, telling us that you have eaten, your sugar levels are normal.
Thank you, Malave Sahib. Thank you, Dr. Vividha. Thank you, Dr. Krishna.
Going ahead with cancer, moving from head and neck to cervical cancer, we move on to the next session. We are talking about a vaccine preventable disease. So having a cancer which is vaccine preventable and has a very high rate of morbidity and mortality is what we are going to discuss. And we are fortunate that we have newer Indian vaccines as well. So to chair this session, may I now call upon our senior gynecologist from Bhavnagar, Dr. D.A. Chawda. He's a laparoscopic surgeon and an IVF specialist par excellence, and he's currently the director of First Choice IVF Center at Bhavnagar, Surat and Vyara. Welcome, sir. Next, we would like to call upon Dr. Vallabh Bodaria. He's a senior practicing gynecologist and has got wonderful hands and vaginal surgery. So seeing him operate is like a miracle. So please introduce the speaker for the day.
Hello. Nidhiben rightly said, since morning we are talking a lot about the malignancy, treatment, diagnosis, radical treatment, reduction surgery, robotic. But this is the real lecture where the prevention is better than cure. And we have a very nice vaccine against the causative factor, that is the HPV virus for the cervical malignancy. For that, we have a renowned speaker, Dr. Viral Patel from HCG Hospital, Ahmedabad. He has done DNB gynecology, MCH in gynec oncology, gynecological oncologist and a robotic surgeon, HCG Cancer Center at Ahmedabad. Dr. Viral Patel is a gynecologic oncologist with experience of over 10 years, and more than 1,000 gynec cancer surgery has been done by him. He is the first registered gynecologist, oncologist in Gujarat. His expertise lies in the robotic surgery and advanced cytoreductive surgery for the gynec cancers like uterus cancer, ovaries, and cervical cancer.
So as we all know, what is the risk factor for that? Multiple sexual partner, low immunity, immunosuppression drug, HIV, smoking, which definitely decrease our immunity. And there are some factors which don't have any reason found yet, like oral contraceptive pills and more deliveries that are also associated with the cervical cancer, but we don't have the reason why. So this is like, I just want to ask one simple question, like as we all know, there is what is the cause of this cervical cancer? As we all know, there is a human papilloma virus, but can anyone tell like how much percentage of the cervical cancer is because of this virus? Any guess? Any resident? No. So, yes sir? Okay, so that's why I just kept this. As we can see, 99% of cervical cancer is because of the HPV virus infection. This is WHO report. They have clearly told almost all cervical cancer cases, 99% are linked to the high risk human papilloma virus only. So, now coming to the vaccine. We have total 3 vaccines available in the Indian market. Previously it was 4, but Cervarix, which was a bivalent vaccine, that was withdrawn from our market. So now we have only 3 vaccines. One is the Gardasil, second is the Gardasil 9, which are from the Merck, and we have indigenously made in India vaccine, Cervavac, which was released in this year, Cervavac. So coming to cost. Cost is, yeah, definitely, as we all know, there is a 4,000 rupees for the Gardasil, 9,000 rupees for the Gardasil 9, and 2,000 rupees for the Cervavac Indian vaccine, which is available in the private sector also. But yeah, when the government setup is going to give, that is around 200 or 400 rupees as per my information. So, schedule, as till now, the information we have and what pediatricians suggest, what companies suggest, and what our FOXY suggests, Federation of Obstetrics and Gynecology of India suggests, till the age of 50, we will give 2 doses. Simple. And once the girl crosses the 15 to 26, we will give 3 doses. And license to use in India for the Cervavac is 0 to 26 years, And for the Gardasil, it is 0 to 45 years. But after 26 years, the efficacy of vaccine is very, very, very less. So that's why that was not recommended to give. Means not recommended means like just we have to inform the patient like there is very low efficacy after the 26, but though they want to take, they can take. So now in the vaccine schedule there is update, so that's why I have just selected this topic. Might be very few of us is knowing this article, which is again from the WHO. Only single dose of HPV vaccine offer solid protection against the cervical cancer. So this article is might be not much of we know because like it is detrimental to the vaccine company. But yes, this vaccine is so effective, even a single dose is giving protection more than 10 years. That is proven data in this article. Whoever want, they can go and read. So after this article, WHO again gave a new recommendation for the vaccine schedule. That is a blanket simple thing. If age is less than 20, give only one dose. 1 or 2 doses. 2 doses is still going on because like they have kept some criteria. Like when there is a low resource setting, then they can opt for the 1, and there is a good resource setting, then definitely they can go for the 2. And once she is around 20 or more than 21, then definitely she should get a 2 doses 6-month interval. And yeah, this schedule is not for the immunosuppression patient, HIV patients, and those people, like they have already mentioned, the immunocompromised individual should receive minimum of 2 doses and where possible 3 doses, right? So this is the again update from the WHO, which is a update in this schedule. Like WHO has told 9 to 14 single or 2 doses, 15 to 20 single or 2 doses, 21 to 26 2 doses. And HIV patients, immunosuppression patient, 3 doses irrespective of the age. So like generally in my OPD, some patients ask, and some of my colleagues also ask, like, is it this vaccine is effective? So let me tell you again data, not my perspective. CDC says this vaccine is effective, and as we can see, they have already found that in the US, the vaccination program started in 2006. So they have collected 10 years data, and they have found that when it is given to 14 to 19 years of the age girl, then the efficacy of this vaccine is 86% to prevent the HPV virus infection. And if it is given in 20 or more than 20, then this efficacy reduced to 70%. So that's why the cutoff is there. When there is a 26, after that the efficacy reduces very significantly. So generally in the most of the recommendation, you won't find preference to give this HPV vaccine after 26. So again, this is like impact of the HPV vaccination. So as we see, like this is meta-analysis. Whatever publication done till now, they have compiled and then given, they have published in 2019. And in that, as we can see, okay, sorry, yes. So here you can see that HPV 16 and 18 virus infection, this forest plot shows us like there is a highly significant p-value, and there is a highly significant risk ratio reduction in the girl 13 to 19 years of the age, 20 to 24 years of the age for the infection with the HPV 16 and 18, which are the most commonly responsible virus genotype for the cervical cancer. But as we can see, after the 25, this forward, that risk ratio is not that significant, like though significant, it is crossing the midline, and that's why the efficacy is little bit reduced. And this is the data for the cervical intraepithelial neoplasia 2+ lesion. which is most commonly progressed to the cervical cancer. So they have told after the vaccine administration for the girl between the age of 15 to 19, there is a significant fall in the SIN2 plus lesion. For the girl 20 to 24 also, there is a significant fall in the SIN2 plus lesion. But yes, after 25, there is very less effect. So this is the Australia data. They have, sorry for that, we don't have Indian data. That's why I'm showing this. Otherwise, I could have very proudly showed that. So in the Australia, they have started vaccination program in 2004 and they have compiled 10 years data, and this is clearly shown that when they are giving the vaccine less than 20 years of the age, then there is a significant decrease in the cervical abnormality, cervical pre-malignant lesion. And this is Sweden data. This is completely showing that they have counted how much cervical cancer incidence after the starting the HPV vaccine immunization program. So they have found when the vaccine is given at the age of less than 17 years of the age, you can see the green line, that is consistently low cumulative incidence of cervical cancer. But after 17, there is a gradually little rise in the trend because the vaccine efficacy decreases. The simple rule for the vaccine efficacy is we have to give it before the first sexual exposure, because this vaccine cannot remove the HPV infection. It can prevent the HPV infection. So we have to give it before the HPV infection occurs in our girls. So this is the recent news you might have come across. Australia is planning to eliminate the cervical cancer by 2035, and they have released their data for that also, because they have seen like how much reduction in the incidence of the cervical cancer incidence after their vaccination program, and they have computed that chart and they have followed that chart, and they are affirmed that they have goal in their country and in immunization program by 2035 they will eliminate the cervical cancer. And yes, there is herd immunity also for that. Like there is decrease in the non-vaccinated women also. The chances of HPV 16 and 18 infection is less after this immunization program. So where India stands? As we all know, we have recently made in India vaccine, and it came in a Lancet paper also. And India is planning to start HPV vaccination program in 3 phases. First phase, I think they have started in 6 of the states. There they are planning to give the vaccine for the 9 to 14 years of the age. Once that states complete the immunization program, then they will run the immunization on their own, and then it will step up to the phase 2, and like in the 3 phases they will cover the whole India. That is the plan of the Indian government. So like this is the recent thing, but already we have one state, they have started the HPV immunization program long before on their own without the help of the Indian government. This is the Sikkim data. Sikkim has started the state government HPV vaccine immunization program in 2018, and they have covered the whole population of the Sikkim. More than 95% vaccination coverage they have achieved by the school immunization program, and that is like commendable. And they have told and they have given the reason for that we need a strong political commitment, statewide mandatory school enrollment, collaboration between the health education department at all levels, robust social mobilization. That is really important. We have to take trust of the all parents, and then only this is possible. And yeah, Punjab has also released the news that they are also starting the state immunization program on their own. In I think 2022 they have released this news. So this is the main slide for me. What is a barrier? Though this much information is provided, all we all know this is the safe vaccine very effective vaccine, though there is no vaccination. And even after this, India has the second most common cancer as a cervical cancer in the all women, right? So this is the data again from the one of the paper from the US. They have showed, in the US also there is a issue. Okay, in the 2015, there is 13% of the parents has a safety concern, which is increased up to 23% in the 2018. So who is responsible for this? Because they don't have that much knowledge. So we are here to give them the information, to get their trust. So we have to act together and we have to decrease this graph. And as I think our previous speaker, Sandeep sir told, like health is wealth. So definitely this is the vaccine which like cancer cannot be prevented by the exercise or some yoga or meditation. But yes, we have a vaccine available. So we have to use it. So now coming to safety, like even my medical colleague also is asking, is this vaccine safe? So this is the data again from the CDC. They have counted, there is a 15K vaccine shot, 29K vaccine shot for the Gardasil, and 30K vaccine shot for the Cervarix. All are safe. And again, this is from the WHO. They have also mentioned no other adverse reaction has been identified till date for the HPV vaccination. And till now, 135 million doses given. Until date, there is no major adverse reaction is found. So I think this is a maximum data which I can give to assure you the safety of these vaccines. But yeah, just let me confirm this. This all data is for the Gardasil and Cervarix, not for the Indian-made vaccine, Cervavac, which is released just now, though they have done the pre-release like phase 1, phase 2 trial already they have, and they have definitely good vaccine safety, but till the phase 4, like data is still yet to out. So generally for our information, what is the most common events reported after the vaccination? Syncope, dizziness, nausea, fever, injection site reaction. So syncope is rare, but it is happening. So that's why healthcare professionals should administer HPV vaccine while the patient is seated or lying down, and make them remain seated or observe for 15 minutes, because the syncope and dizziness is little common sometimes. So this is the last slide which WHO has released, I think in 2020. They have initiated the cervical elimination program, and there is a 3 goal to achieve this aim. There is a 90% girls should be fully vaccinated, 70% should be screened, and 90% of the women should have the better treatment. Thank you. Thank you very much. Any questions?
Viral sir, quick question. As India is 142 crore and USA is 40 crore, then we have only 9 valents and Gardasil plus 13 valents in USA. Don't you think that Gardasil plus is required for India, looking to the more population? Still we have Gardasil 9.
Yes, sir.
USA has Gardasil plus 13 valent.
Gardasil plus?
Plus, yes, 13 valents. So why not in India?
Sir, actually, till now, they will release step by step, first of all. The thing is that once you take a nonavalent, which is already Gardasil 9, they have to, like our market is not that much keen to take that. First of all, we have to give the quadrivalent. Once they will sell the quadrivalent, then they will like give the nonavalent. In HCG also, that is like our thing. Our patient is now regularly taking like quadrivalent vaccine, 4,000 rupees a shot. But 9,000 rupees a shot, sometimes some people are still hiccup. So that's why 13 is little, I don't think so it will come very soon. But first they have to, like India has to accept nonavalent, and that's why after that they will release. Otherwise I don't think so it will come as soon as possible.
Can I take that question a little ahead?
Hello.
Quadrivalent itself is enough, sir, for Indian population, because we are a huge population. So nonavalent will not be affordable, and if we take good quadrivalent coverage, it will serve the purpose.
But for me, madam, main thing is like we have to convince first. If we will convince first, then only we can convince our patients. And cost is now no issue at all because we have our made in India vaccine, so we need not to rely on the Merck and Gardasil 9, doesn't matter at all. So we can just carry on with the quadrivalent vaccine, whatever is made in India, Survivac, and we can keep going that vaccination, then we can jump to the non-avalent. Welcome.
Hello. Sir, my question is that, the HPV is a sexually transmitted disease.
Yes, sir.
What about the counterpart of the female, that is a male vaccination to prevent the cervical malignancy?
Sir, actually, when you see the Australia data, in the Australia also they have started the female vaccination first and then the male vaccination, because generally what happens, the most common thing we will consider first, because there is a most commonly cervical cancer. So generally every country will impact where is a major cost effectiveness. So definitely they will try the female vaccination first and male will be later. Because only male has a penile cancer, throat cancer and anal cancer. Everything is because of the sexual activity. So that might be that cancer cases is not that common as compared to cervical cancer. So male vaccination in India is, I don't think so it will come very fast. First we have to achieve the female vaccination in the major population.
My question is that to prevent the transmission of the HPV virus to the female, we want to, what I mean to say, to protect the female by male vaccination.
Yeah, understood. Sorry for that. So the thing is, I have told, like we have to give HPV vaccination before the first sexual exposure. Once that female is getting the vaccine before sexual exposure, then definitely irrespective of the opposite partner is HPV positive, doesn't matter. She is already immune, so there will be no chances of cervical cancer in that part. Okay. That is only male part remaining.
Cervical cancer is concerned, male vaccination is not required.
No, male vaccine is required. Now the Australia
for cervical cancer, it is not required for male vaccination.
Yeah, provided we will give the vaccine at 9 to 14 before the first sexual exposure. This age is because like that only they have decided actually. When you, like there is a inherent data, like they have counted so many questions to the young girls and then they have come up with this age. And 9 age is because like before 9, if they will give the vaccine, then that won't be that much serotype generation in the body. So that's why they have started this vaccine at the 9. And by 14, or after 14, majority have started first sexual exposure. So that's why this cutoff is.
Thank you very much, Dr. Viral Patel,
Thank you.
having a nice presentation on vaccine.
We would request our chairpersons to felicitate the speaker. May I call upon Dr. Seema Bakshi Madam to do the honors and felicitate our chairpersons. Thank you very much, chairperson and speaker, for that enlightening talk. So it is rightly said that an ounce of prevention is worth a pound of cure. The other message we get, I think, Dr. Viral, is that we have to catch them young. So next we are talking about something where again prevention has a big role, and it's a professional hazard we all encounter in day-to-day practice. And the greatest hazard in life is to risk nothing. So once you are into medical practice, it is a professional hazard. To do the honors, may I request Dr. Ranjit sir to take it forward?
Moving to the next session, may I call upon the stage the chairperson, Dr. Urvesh Shah and Dr. Paras Shah. Sir, please come on the stage. Dr. Urvesh Shah is Professor and Head of Microbiology Department, GCS Medical College and Hospital Research Center, Ahmedabad. He is also Member Secretary, Ethics and Scientific Research Committee, and Honorary Secretary, Ahmedabad Medical Association, and Member of Standing Committee for Medical Student Network, IMA Headquarters. Dr. Paras Shah is Head Department of Gastroenterology and Hepatology, Harmony Super Speciality Hospital, Rajkot. And he is also a Fellow of Indian Society of Gastroenterology and President, IMA Rajkot. Chairman sir, now stage is yours.
Thank you. It's an honor to be at Bhavnagar. Congratulations for such a wonderful conference, wonderful location. Congratulations to organizers. It's an honor to introduce Dr. Venkat Iyer, a very good friend of mine, senior most gastroenterologist of Bhavnagar, laureals in MBBS and MD medicine, he did done from BJ Medical College. He did his DM in gastroenterology from CMC Vellore. He is an astute clinician and academician, has got various awards on national level. He is also a speaker at National Indian Society of Gastroenterology and various levels. So it would be really pleasure to hear him at Bhavnagar itself. And yes, a topic which is very important, accidental prick of HPSAG was positive patients. So Venkat, we would like to hear something from you on this. I'm sure it would be the most entertaining and enlightening session. Thank you.
A very good afternoon to all of you. So after the post-lunch, I think it's a sleepy session, but I'll try to keep my topic lively, and I'll be try to not present very boring forest plots or data for you. This is a very, very common scenario that I get a phone call from one of my doctor colleagues that, sir, or from the juniors, particularly residents at the medical college, that I got pricked with the HBsAg positive needle. Now what do I do? What next? So that is the topic. I would, next, sorry, yeah. So first of all, greetings from Bhavnagar, the host city, and I am sure you are enjoying this meeting, and this is the Yuvraj of Bhavnagar, whom you will be able to see in the evening during the inauguration. So coming back to our topic, so the first reaction of a person is like when he gets pricked by hepatitis B positive needle is something like this. First of all, it is a shock, then it's a denial, and then he says, why did I become a doctor? Why did I not take care? Okay, so that is, these are all the reactions that one has when but you know, knowledge is power, and if you have the knowledge that what to do when you get pricked, then I think a lot of things can be preventable, and it's nothing to be worried about. The biggest problem is that these needle stick injuries go unreported. 8 out of 10 needle stick injuries go unreported. So first of all, you need to speak out. Yeah, I got a prick, so we can take care of it. And I will be dealing with my topic under the following headings: the definition, the risk, how to avoid a needle stick injury, what is the immediate action we need to take after a needle stick injury, what are the treatment approaches, and in an institute, how to implement reporting and registration, and how to take care of the staff. Okay, because it not only does it affect doctors, it can affect your nursing staff or your paramedical workers also. So you need to take care of them as well. So first let us come to the definition. So what is the definition of needle stick injury? The accidental puncture of intact skin by a needle during a medical or a surgical intervention. So there is also something, I will also mention that there is sometimes accidental exposure to blood, the unintended contact with blood and body fluids mixed with blood during a medical or surgical intervention. So it can be mucosal, it can be splash in the eye. So you know, the treatment is similar. So I just thought that I will take this also along. So what is the risk? So this is very important for us to remember. So whenever we get pricked by a needle, we are always worried about HIV, right? However, if you see here in this list, HIV is the least transmissible of all, okay? And hepatitis B is the highest transmissibility. So for example, so HBV risk of needle stick injury of contracting hepatitis B is 30%. Okay, whereas HCV, hepatitis C, is 3% and HIV is 0.3%. So, if I have a needle and I prick 100 patients, needle with hepatitis B virus on it, and if I prick 100 patients, 100 subjects, then 30 will turn positive. Okay, so that is the level of infectivity. If I have a same needle of HCV, if I prick 100 people, 3 will become positive. And if I have a HIV positive needle out of 1,000 people, 3 will become positive. So you need to understand the magnitude of risk of Hep B, which is the highest in comparison to the other 2 viruses. So I am not going to discuss about HIV and HCV, what to do, but we will stick to our topic of, because that itself is another lecture, so we will stick to the topic of hepatitis B. So there are some risky techniques that we do while we work, or our staff does while they work. So what are the risky techniques? First technique is the recapping of the needles. Okay. Then during surgery, the surgeon is very happy finishing the surgery, and during wound closure he tries to be little fast, and that is the time when that suture needle pricks the skin. During a biopsy, and suppose a uncapped needle is ending up in a bed linen, surgery or clothing, the class 4 employee who is cleaning it, he gets pricked by the needle. Also, if you are taking an unsheathed needle, used needle to the waste bin, at that time it can cause an injury. During the cleanup and transport of waste material, during disposal of biomedical waste, when you are doing very complex injection techniques, or like there are some techniques like the Z technique and everything, if you are using those techniques, then that can cause, in a very high stress situation, for example in the trauma unit, accident and emergency unit, you don't have time to, you have to save the life of the patient. So when you have a mass emergency, or when you are having kind of a very difficult labor or a very emergency cesarean section, or for our case when we are doing a bleed, GI bleed endoscopy, so there is blood splash everywhere. So you can't prevent it. So these are the risky situations where we actually face a risk, higher risk. So there are certain factors. So first is the patient factor. So the source patient who has documented infection, if he is active, very high viral load, then that can lead to more chance of transmission. If the type of, what is the type of exposure? So percutaneous injury, now sometimes there is a hollow needle, sometimes you have a solid needle. So hollow needle can retain more blood, solid needle retains less blood. The type of needle, very thin needle will retain less blood, thicker needle will retain more blood. So a lot of factors are there. Mucous membrane exposure, non-intact skin exposure. Sometimes you have psychiatric patients who can bite you, and that exposure. Fluid and tissue exposure with significant risk. So blood, fluids containing blood, and potentially infectious blood or fluid or tissue. And if you yourself as a health worker, if you don't have immunity against hepatitis B, then meaning you are not vaccinated and you don't have a documented high titer of anti-HBs, then that can lead to higher chance of you getting hepatitis B. Which are the other viruses? Not only HIV, HBsAg and anti-HCV need to worry about, HCV need to worry about. There are cytomegalovirus, Epstein-Barr, parvovirus, syphilis, Yersinia, and even malaria, plasmodium, that can get spread by needle stick. Okay. So now we'll first come to prevention, then we'll talk about what to do when we get. So how to avoid a needle stick injury? So it's a universal precaution. Whenever you are handling any procedure, what does universal precaution mean? It means that consider every patient as positive and work like that. Wear gloves for whatever small procedure you are doing. And what do gloves do? This picture shows that if you directly get pricked by a needle, then you may draw more blood. But if you are wearing a glove and if you get pricked, the volume of blood exposure becomes less. Even if you get pricked through the glove actually filters out a lot of the blood and the volume of exposure is less, which reduces your risk. So always wear gloves while you are doing any risky work like that. And also insist your staff, provide a good stock of gloves to them. Gloves are very cheap. Okay, you don't need to save on them, right? Then needle stick injury, don't resheath needles. Don't try to put them back, and now there are, for those who, biomedical waste disposal, you have to keep that needle cutter right where you are collecting blood. So you can immediately destroy the needle and, just discard it. So it won't harm anyone else also. Then safe handling, proper biomedical waste disposal. Do not overfill these safety boxes. and never leave needles unattended. So general measures: avoid recapping, resheathing, you use puncture-proof rigid container. How to prevent? Get yourself vaccinated for hepatitis B, personal protective gear. We all know we have gone through COVID, so personal protective devices, safety features of devices. There are certain devices, they after one prick, and if you try to recap, there is a big, rubber ball. So if you it will go in the rubber ball. You will not be pricking yourself for that. And proper disinfection of contaminated material in hypochlorite solution. Now we come to what we should exactly do when you have the needle stick injury. So 3 things. Initial, once you get pricked, clean it, report it, treat it. Okay. So in cleaning, so once you got pricked and you have blood, allow the blood to flow. Don't squeeze and don't try to remove the excess blood, right? And why this is? Because if you squeeze, then it releases something called factor 3 or tissue factor. If you have read the coagulation cascade, factor 3 is tissue factor. So if you squeeze, lot of tissue factor is released and actually the virus enters more easily inside. So don't squeeze, just allow the blood to flow. Wash with soap and water. Do not scrub the affected area, just lightly wash it with soap and water. And in a lot of the main reflex as seen to us is like when you have needle stick, you just suck the blood out, when you see in movies like snake bite or blood or something, they'll suck the blood out. So don't do that. Do not suck the blood to remove the blood, because again your mouth will get infected and you can also pass it on if you have oral ulcers. It can actually infect you more. Report it. So if you are working in an organization, please report it, or also encourage your staff to report such an incident to you if something like this happened. And in a corporate hospital or an institute, there is always an infection control officer who takes care of all such injuries and guides the staff and patient. And third is treat it. Now how to do that? We'll come to that. So this I have already discussed. Just one more thing is that you can wash it with soap and water. Otherwise you can also use 70% alcohol. For mucous membranes exposure, just rinse with water or normal saline, but do not use alcohol. Okay. Report the incident. Baseline sample of the injured person, HIV, HBsAg and anti-HCV should be taken. And if it is not done in the past, it should anti-HBs antibody with titer should be done. This is the single most important test that a person should be having a report. And even while monitoring, the patient has to be monitored, the person who is injured, healthcare worker who is injured has to be monitored at 1 month, 3 months, 6 months and 12 months. And repeat the test for all the 3 viruses at least. If the source is a known case of hepatitis B, then test the source for hepatitis C and HIV. If the source says, no, I don't want to give any more blood, it is now the patient right to refuse sometimes. So then patient is assumed to be a carrier of the virus and treated. Okay. And needle, if it contains even a visible drop of blood of the patient, then you can send that blood to test the viruses for the patient. Now, treatment approaches. So, we come to the tests which are required for a healthcare worker. Once, this much test we should be having: baseline HIV, anti-HCV, HBsAg and anti-HBs antibody with titer. Now, how to interpret this report? So, anti-HBs antibody titer is a level of immunity against hepatitis B in our body. So, if it is less than 10, then you are not protected. If it is more than 100, you are super protected. You have robust immunity. You don't need to do anything. If your level is between 10 to 100, that means you have a partial immunity, and you may not require immune globulin, but you may just require a booster dose of the vaccine. Okay. And if you are less than 10, then you require hepatitis B immune globulin plus vaccine full course. Okay. So there is a lot of confusion among people regarding the dose of hepatitis B immune globulin. So the dose is 0.06 ml per kg, or it is 12 units per kg. It has to be given IM. The preparations are available in 100 IU per ml, or some companies also have 200 IU per ml. So for example, if there is a 75 kg person, so 900 international units is the dose required. So total dose required is 9 ml. So 9 ml IM, if you want to give, you have to use both buttocks, 4.5 ml in each buttock. Or it is good to use the concentrated preparation, 200 IU per ml. So the total volume becomes 4.5 ml. So you can actually again divide that into 2 parts and give on each buttock. Okay, so that is the way we guide our patients. And at the same time, on the deltoid, you have to take a first dose of hepatitis B vaccine. So this I think we already discussed. This is the, in a chart form. If unvaccinated, then Hep B immune globulin plus vaccine full course. If patient is already had an immunity of more than 100 IU, then no treatment is required. You have to ask your doctor colleague or healthcare worker not to worry. And if he is between 10 to 100, then a single dose booster dose of vaccine is sufficient. So yeah, so this is just again an algorithm on how to approach, how to implement and register. So first of all, prevention again is better than cure. So safe OT practices, awareness among healthcare workers. The next thing that you should do after going back from the conference is ensure that all of your staff is tested for hepatitis B and vaccinated for hepatitis B. Because if your healthcare worker, your staff gets pricked, then it is actually ultimately your responsibility. Immune globulin is extremely costly. So for example, adult, so if I use 900 international units for an average 70 kg person, the cost comes to somewhere around 28 to 30,000 rupees. So it is very costly. So it is better, more cost effective to have a staff, all staff hepatitis B tested and Hep B vaccination done for everyone. And in institutes where I studied in Christian Medical College, Vellore, there was a policy that if you are a resident, then you don't get your first stipend unless you get tested for anti-HBS with your own money. You have to pay, get your anti-HBS done, and titer you have to show to the staff clinic, and then only that staff clinic medical officer will sign that okay, this doctor's anti-HBS titer is done. So then they will give you whatever, if your titer is low, they will advise you, give you vaccine, and then only they will give you your first stipend. So that was the kind. So institutes need to have such a policy, and this policy in certain institutes is compulsory to do. So healthcare is dangerous work. So safety first and be safe. Thank you very much for your kind attention.
Thank you very much. It was really honor, can say the proud to listen from Dr. Venkat Iyer. Once a wonderful, sincere student during MBBS might have learned from me some preliminary about the hepatitis B, but now grown up with so rocket speed career and wonderful orator, so convincing. Especially the points covered by him, no recapping. Yes, prevention is always better than care. Hepatitis B vaccines, these two are very important. And I also like to emphasize on the reporting. The reporting part is always missing in very many setups. They are reported too late. At least reporting થઈ જાય, આપણને ઇન્ફોર્મ થઈ જાય અને આપણે ડૉક્ટર વેંકટને પૂછીને પણ આપણે મેનેજમેન્ટ કરી શકીએ. So, and HbA1c titer, yes, that's important thing, and management according. So, wonderful and very nice talk. Thank you very much, Dr. Venkat.
Questions for the house? Can we take one or two quick questions, sir? Gosai sahib, if you allow. Yeah.
So if anyone has no question, then I have one question.
Yes.
Venkat, caveat, as you said, anti-HBS titer versus vaccination. We have realized that cost of hepatitis B vaccine is very less in comparison of anti-HBS titer.
Yeah.
And why should we go?
So
if
I will,
patient is asymptomatic, directly go for vaccination.
Yeah, I will elaborate on that. So the issue is when it comes to health workers, you have to be 100% sure. So the vaccine efficacy is 95% in hepatitis B. Okay, so there will be 5% who will not respond to the vaccine, who will not have a titer. So this is called primary non-response. So if suppose I am a healthcare worker and I fall in that category of primary non-responder. So, and even in spite of 3 doses of vaccine, my titer of anti-HBS is not good. So, 2 things. If I ever get pricked, I need to take immunoglobulin. Okay? And the second thing is there are some strategies. So, you can use double dose of vaccine, you can use accelerated regimen, you can use there are some vaccines with some adjuvants which you can try. But this 5% chance, at least in healthcare worker, we should not take. So that is why it is always recommended to do anti-HBS and judge. And supposing, so if it's a big program like in an institute, so if the anti-HBS titer is done, they are good to go. They don't need a vaccine. My titer was done at Vellore. It was more than 1,000. So they said no vaccine for you, go. So it saves the money for the institute also, because vaccine is 3 doses. 1 dose costs around 100-150 rupees. Titer costs 400 rupees. So it's almost same. So if you want to come to the cost, so 3 doses of vaccine is equal to the cost of anti-HBS titer.
So thank you. To sum up, it said that all healthcare professionals, we must ensure that they are vaccinated for hepatitis B. There is no need of booster doses if you have already taken 3 doses. But yes, anti-HBS levels of all healthcare professionals can be done on a periodical basis. If your anti-HBS levels are falling down, you can take the booster dose and you are at least safe as far as in case in worst scenario you get hepatitis B prick. So that's the carry-up message which Dr. Venkat would like to give. It was really a nice session. Thank you. We call the session off right on time.
Hello. Now I request Chairperson Sir to honor Dr. Venkat Sir. I request Dr. Naresh Gohil Sir to come on stage and honor both the chairpersons. Thank you, Dr. Naresh Bhai, and thank you both the chairpersons, sir.
So for the next session, our chairpersons are Dr. Nilesh Parekh sir and Dr. Hiren Kothari. Parekh sir is head of the Department of the Ophthalmology in our Government Medical College, Bhavnagar, and he is also a chairman of the scientific committee of this GIMACOM 23. Parekh sir is very active in medical council matters. He is a member of executive committee of Gujarat Medical Council. He is also a member of ethics committee of World Medical Association and program officer for the National Program of Control of Blindness and Visual Impairment for Bhavnagar. And so many other positions he is holding. Dr. Hiren Kothari is orthopedic surgeon at Shiv Hospital, Rajkot, and also office bearer of IMA National Headquarters. Dr. Parekh sir and Dr. Hiren Shah, Dr. Hiren Kothari are both the chairpersons are very good friends. Sir, please, sir.
Thank you, and we welcome our speaker, Dr. Hiren Shah, on a very interesting and a little offbeat topic, 25th hour. It is going to be very interesting and motivating talk also. Dr. Hiren Shah is a well-known pediatrician, of course, but over and above that, he has created a houseum, means his house has been turned into a museum. And there are thousands of locks and keys in his collection. And he has different hobbies, and he is an avid traveler too, and probably having traveled more than half of the world. And of course, photographer, blogger, art collector, puzzler, and totally a multi-talented, multifaceted personality. So we will have a good time listening to sir.
Good evening, one and all. Thank you for the nice words of introduction. I am thankful to the organizers for extending this warm invitation to talk on a subject which is quite close to my heart, our 25th hour. The emerging picture on the screen, obviously it's me, but it can represent anybody or everybody from our medical fraternity who managed to put a brave face and broad smile in spite of being filled, crushed under the pythonic issues of the day-to-day medical practice. He's suffocated because of various reasons. At the end of the day, he is tired because of frantic and erratic long hours. He's under the constant fear of medico-legal litigations and then physical assaults these days. He's angered and he feels frustrated for not getting time for the family and friends, forget for the self. Outcome is gross distress. How to survive this? I know I cannot control any of these factors, but as we say, you better adjust your kite rather than fighting against the wind. Need is to bring change in I or the self. Little modification in approach towards life and work probably take one from distress to de-stress and reason of happiness. I recall this particular medical conference we had at IIM Ahmedabad. My many friends are here today who were the organizers of this conference. Dr. Vidya Desai, Dr. Mona and Parimal Desai, Dr. Jaswant Darbar, Dr. Mehul Shah, all they graciously gave me a platform to hold a photo exhibition of this kind where I used some 80 feet long canvas, some 100 pictures and 12 stanzas to portray similar theme. So let me start today where I ended on that day with the last stanza, which reads like this. A doctor's life can be summed up in just a few words. Patients, hospitals, disease, medications, injections, infusions, deliveries and operations. While these are all part of our 24 hours routine, it is the 25th that is our special hour. It is that remedial hour which can even escape or release this entrapped medical who is running frantically in this 24 hours time machine. So let me take you on a fast moving images creating a pictorial journey, our 25th hour. This term was coined some 20 years back by my wife and me, especially for all the professionals who are having time as the most precious commodity. Our medical fraternity stands top in the list. And when I say today, hour is incomplete without you. But what about 25th hour? I use it metaphorically, symbolically to denote that time and state of mind, that time when we are busy with our loved activities, pursuing some hobbies and passion, that time when the state of mind gets filled with joy, bliss and happiness. So in short, I try to equate our hobbies with the passion, with the 25th hour. But we all know passion cannot be quantified nor can be assessed on the scale of 1 to 10. But today it is my humble attempt to bring to your attention the value of hobbies, the power of passion in our life. And for that, Let me borrow this figure of 10 from the legendary one, our 10 Tendulkar. Eventually in the course, I'll give you very strong 10 reasons why we should follow hobbies. I'll also try to prescribe some 10 hobbies which may prove therapeutic to we doctors. At the same time, I'll try to give you some plugs which will prevent the time leak from our clocks and calendars. And also, I'll share my 10 activities and hobbies at some or other stage of my life which made a great impact on my life and career. I call it a sinful journey for the very simple reason that there will be a lot of I, me, mine, self-portraits, some personal stories. But then, there will be some novel kind of hobbies and activities which is not heard in this part of the world. At the same time, this narrative is important to nurture this particular concept. Also, I'll be happy if someone of you can get inspired from this to accommodate that 25th hour in your daily schedule. And what can be better occasion than this? Because 20th October, that's today, happens to be the National Make a Difference Day. And I'll try to sensitize that 25th hour is in everybody's life. Just you need to identify that. Also, 28th October happens to be the International Animation Day, and you all will agree that mere words or the graphics, these animations create greater impact to tell any kind of story. And for me, this animation day is every day. Art and words, playing with crosswords or play of word plays or making graphics, doodles, pictorial puzzles, that has been my hobby for last 30 years. So let me first take you to my childhood at the age of 10 again, where I got hooked to my first serious hobby of philately, stamps collections, first day covers, and these stamps proved for me windows to the world, and I was trying to visualize the people and places far off. Probably my future travel bug was conceived at that time, and the primary lessons in collecting, cataloging and classifying was probably I got primary lessons at that stage. I came to Ahmedabad in 1984, almost empty-handed, but with some gold medals and laurels, lot of grit and determination to settle at my native place. I started with this modest 6-bed nursing home in Maninagar. I applied myself, gradually expanded to this 30 beds, full-fledged Shaishav Children's Hospital. Now I was quite busy, successful also, rated by the others, but then I realized I was spending all my time in the hospital. What about my dreams? So my wife and I decided to restructure our practice and started taking time for this dream of traveling. This particular picture is quite suggestive of our travel to more than 50 countries, more than 500 international destinations, taking out time of almost 6 to 8 weeks every year for last 30 years. Incidentally, this is a picture which fetched my first international prize in a Lonely Planets category of travel when I shot this picture from the moving train in Alaska. And then this particular dog tours, what I call for about my travel, started along with many other different hobbies. The emerging images on the screen, they are the list or other group of the activities I am indulged, and though they look diverse, but you will realize how interestingly they are interlinked and interdependent. Of course, everybody travels these days, but for me, the travel was a game changer in my life. Not just fun, it was kind of education and knowledge. I could spend quality time with my family and children, especially during their formative years. More than that, I could make some great friends who could enrich my travel experiences. At the same time, my hobbies were taken to the next level. And one of my most loved hobby of photography, I could sharpen the skills and establish as a serious travel or street photographer. Even after returning back home, our journey continued in the form of making albums, scrapbooks, writing blogs, and even holding photo exhibitions in the private art galleries for the public viewing. We started contributing as a travel column in the local newspapers, gradually to the magazines of national and international repute. All these years, we are searching captions for the stories. Now, media started writing for us, and different kind of articles started regarding our multiple hobbies or activities. But then more they took fancy was our home. This is, of course, we took almost 4 years to build, and then it's a kind of the house which we say is a fusion of tradition and technovation. But more than that, it's a repository of our most loved hobby of collecting, some 10,000 artifacts divided into some 25 thematic collections spread across 4 levels of 10,000 square feet area. It was by no means a conventional house. But then, how to call it a museum? Because nobody lives in a museum. So we came out with a new term, which was more than a fusion of house and museum. It was a cryptic calligraphy, where we call it the houseum, of course, but there is a museum hidden in this particular houseum. Many different subjects of the museum quality collections, like locks, clocks and peacocks, what you read, some 400 peacock figurines, some 100 chiming clocks, but more than that, we are more known for my locks collection. There are many questions about my collections. I started collecting some 25, 30 years back. Any lock for its size, shape, age, antiquity, story, history, complexity. I amassed almost 2,500 locks. Of this, almost 500 were the trick locks, which happens to be the biggest collection in the world. No wonder it found places in the many record books across the world, but then more than that, my lock collection put India on a very prominent way on the world map. And I got opportunity to address different communities in different countries, like say, based on the Hindu philosophy of life in locks in Germany, even students of engineering IITs, I could speak on the technicalities and complexities of the inner mechanisms, and even far off places, like this in China, where nobody speaks English, language was a barrier. So I could successful in projecting these rusty and crusty tiny metal pieces of Indian origin as one of the most ancient and premium puzzles in the world. And that drew many different kind of people across the world, writers, books of the journalists, collectors. But one specific group called as metagrobologists, means one who are involved in puzzling. They came in 2006. Right away they gave me an invitation to talk on give a keynote lecture in Australia. For me, it was a kind of a Pandora's box open. I have never seen beyond Rubik's Cube, though puzzling was my most loved hobby. But then these were far more refined and playful, far challenging and complex, beautiful puzzle pieces. I started to get chance to play with them, solve with them, and gradually acquire them. And now I'm having almost thousands of this kind of puzzling, mechanical puzzles. I was the first ever Indian in this particular group of International Puzzle Party, what they call, in last 40 years. Selections are by many stringent criteria. But in the return, I got chance to now have different destinations in the world to give my presentation on different topics, create articles in their newsletters and journals. Gradually, I started designing, taking part in the design of the puzzles, and new kind of hobby, or you can say activity, started of making these mechanical puzzles. Even my children, they are one who are holding or arranging are these puzzles designed by us only. Same way, this particular only I am wearing is a puzzle. Just recently, last month, we have here in Jerusalem, just before this Israel-Hamas war erupted. But then this was a day very important in my life. I was a proud Indian standing in this particular convention center in the Paris, where I could launch my, virtually of course, my enigmatic, most ambitious project which was built at the top floor. I could portray the wisdom and skill, talent and this craft of our forefathers, because I collected some more than 1,000 objects of these different categories made by Indian craftsmen and artists. They are displayed there in my enigmatic at the top floor, and I could combine there even unconventional combination of many subjects. Just for example, the aesthetics and mathematics been shown here about the Fibonacci spiral series. Same way, this is a golden ratio loved by the artists. So many these kind of fundas are incorporated in making this new place. And with this enigmatic, now my houseum, it looks taller in all senses. Riding on this appreciation of compliments with a euphoria, we embarked on a very next project, which was quite ambitious, of course, at this stage and age of our life, especially my children, they are away in the USA. But we decided to build a new place. Now we call it Houseum Next. And of course, it is a continuation of the same, it's a celebration of our rich Indian heritage. But more than that, that whole building has been dedicated for my updated and expanded lock museum. These are a few images of them. Still, it's not open to the people, but after 15 January, I will start giving private viewings. So friends, this was my sinful journey of my, enough of blowing of trumpet, but then ball is in your court now. Let's start get going with the set of 3 questions commonly encountered are asked by people: why, how, and what. Let's reflect on them, but first tackle this: how. How to find time for the hobbies. It's like Steve Jobs says, if you want time, you must make it. It's never served on the platter. You have to literally extract it from your daily routine. You have to literally steal it from your clocks and calendar. It may change for person to person. Everybody has different type of schedules and lifestyle. If somebody asks us how we get time, for us it's at the cost of personal comforts. We come out of comfort zones and then sometimes to follow these hobbies. At times we compromise with our social engagements. Even it comes harsh on the financial balance sheets also. But most important for me and my wife, Namita, it was a curtailing our professional aspirations. And it's all about micromanagements where one has to identify their needs and where to put a comma or a full stop. But then we have to set our priorities in life. It's all about some sacrifices and compromises. As we say, our life, student life of medical doctor is the longest and hardest. And as been said that we break our backs with the bags of bones, and we spend our prime of the youth in the grime of the medical wards. With the bright future we expect, and then when we start the things, there are different types of work and commute, we all realize that most of our time spent in this. There start family, and then social responsibility, and they keep on mounting, they never stop. That colorful rainbow, what we have seen or dreamed, has been smeared into this chaotic colorscape. The art to find the time, the art is to pursue this white space in between. And that is exactly called as white space. This is a scientific term more used in computers and graphics, but then even educationists use this day, which says, that these are the gaps in our calendar. We have to identify them, consolidate these chunks of time, and then channelize for some constructive activity. As today we are talking about this hobby, let's talk, or any constructive activity can be done if we just are aware about this white space in our daily schedule. There are two other areas we need to dwell upon, but then multitasking, we all doctors are adept, especially private practitioners and women amongst us, we must salute them because they are managing both fronts, home and hospital, very efficiently. So they are there to have these multitasking skills. Time management, especially, basically it's a misnomer, it's a self-management. But then, we call it muda or a cane chair. Here I am going to asking you to not relax, but then to find a remedy for our time leaks, because it's a Japanese term which makes one important element of the triad of three important names, muda, mura and muri. These are important basic lessons in the management to increase the productivity, and muda means waste or uselessness. So today we'll be talking more, I held a workshop about these 25 mudas in one of the research conferences. As we are sticking to number 10, just let me take out these 10 kind of activities where we can save our time. Of course, we all know this because every now and then we are bombarded with this kind of messages, but then as we just can read this, learn to say no and give others authority, or delegate the work and avoid time overworking on this particular phone or social media. If we just be consciously following this, at least few of this, we can save a lot of time which can be used for any useful or constructive activities. But then this is a million-rupee question. Why I should pursue you to pursue hobbies in the life? Just for the fun? Yes and no. Because yes, at the end of the day, as we heard in the morning session of Dr. Sulirsha, that ultimate aim in the life is happiness, and these hobbies give us endless happiness. But more than that, they impart fitness. There is no shortcut to physical fitness. That daily regime has to be there, but then these hobbies are important for fitness at emotional level, mental level, and spiritual level. They can, if follow it in a sincere way, it can even go to the meditative or nirvanic stage. And how they do this? By energizing us as a stress busters, tension tamers, mood elevators. In short, they help us to relax and unwind. We have observed during COVID outbreak, one of the scary and the barren patch in our life, but whosoever were busy with their hobbies or activities, they could survive it this time quite well. And same way, stress busters during tiring stage, retiring stage. For elderly, this may prove as a healthy time pass. Keep them away from isolation or loneliness, depression, keep them cheerful. Even Alzheimer's disease kind of illnesses may be pushed away. For young adults who are on the run more so in this modern life, because of stress, this new lifestyle diseases are creeping in so fast. I think these hobbies will act as antidote. They will give, at least prevent or help them to be away from these health elements and issues. And we all know this is all the interplay of healthy and happy hormones in the brain, and they are the ones responsible to give or impart all these advantages. I already said about the friends, but then one important factor what I got to observe was the fellowship. I could get chance to mingle with this kind of people. We generally doctors don't have opportunity to peep in their world, and I tell you, I endorse that. It is so fascinating. Generally, we doctors remain in our own groups. We hardly get to know about how artists works, what is the life of journalist, what is a photographer, how he's working in the field. So being involved in these hobbies, I can tell that hobbies will give you different type of experiences in different groups. And these people, what we are seeing on the screen, we would have seen on the either news channels or the cover of magazines like British Navy's Admiral or a Nobel Prize winner of mathematics, New York Times editor, or this lady, she happens to be the head of the Russian space mission. I can call them my very close friends. We get chance to mingle and meet and go to each other's place. Some of them, there are a long list of this kind of people who have come also to India. And that's FAB is a short form of the fabulous. We get chance to have this FAB feeling like as if on the cloud 9. And then, of course, I had these kind of opportunities in my young days during the academic career. Those were the real FAB moments for me. After having started in the practice, probably I missed that. But then my joy knew no bounds when I was declared or other addressed as icon of Indian intelligence. Had chance to work with this British actor in the series of the Hong Kong about the collectors. Then I was luckily, it was by fluke that I was the first of the batch of the one who were interviewed on the Sydney radio, whose podcast in vernacular language, we are the first batch in the world. Same way, it's, very kind of satisfying to see that you are projected as a star feature in the next issue of this particular renowned magazine. And even somebody like him, this person is 85-year-old, owner of the biggest museum in the world, when he flies down to your place specifically to see your museum. Of course, it's a different kind of perception you get in the society. You may be labeled as famous, interesting, warm, lively, and multi-talented. So that's again, that gives us little euphoria. Of course, there is a downside also in this. And like not the Dashavatar of the 10-headed multifaceted, but then this Ravan, society may call you eccentric. At times when I talk like this, somebody may comment a boastful, unfocused for the patient because I'm running, away from the practice quite a while, or this way. That's the way how society perceives. We don't have to beat the drums for the fame. It comes by default. Everybody loves this. And many kind of appreciations from different parts and corners of our country and places, just to pick these few that we are selected on 8 Ahmedabadis who brought international fame, or kind of this magazine which came up with the 60 interesting people in India in the 2012 issue to whom one should meet and visit. Same way, just 8 days back, in this newspaper of the Middle East, it's a leading newspaper, English newspaper, we were featured about our Hausium and Lock Museum on 20th October, last Friday. So apart from these all advantages, still few more, like somebody smart can go for good finance in this and make good fortune also. But then what? Somebody may ask, we are so busy in the practice. What can we do at this stage or age? It's like from the bunch of the keys, you have to select a very specific key for a particular lock. Likewise, depending on your personality, your kind of practice and daily routine, your aptitude, your cherished dream, one can go. So it's been in shortly called as no essence in yourself. It's again a key. And I have just, after discussions with many people and research on the internet, I come with the list of 10 hobbies which can be followed by even the busiest doctor, and which are the great stress busters in addition. Depending on if you are a nature lover, go for gardening or like a trekking. Will you allow me a few minutes? I'm giving you extra 1 hour. So if I can ask a few minutes more, because I'm just a little away from that. So let me tell you, friends, once again in life, do fall in love, not necessarily with a person, not with your profession, but with an idea, a long cherished dream and a passion. And add 1 more degree of DCH, not Mehul's pediatrician's diploma in child health, but it's a develop and cultivate a hobby, at least one, at any age. age is no bar. There are hundreds of examples you'll find on the, stories and internet. So get started on some new hobby or rekindle or ignite your dormant one. Select it wisely, but pursue it passionately. So to wrap up the things, one has to earn, concentrate on the practice. We need that for us, family, and to pursue some kind of hobbies. At the same time, we need to continue to learn, like this conference we are attending. This will again give you more success than name. But unless you have very strong desire, unless strong yearning to go for that happiness through hobbies, probably, and that morning slide, the same one here I use, happiness is not a destination. Don't wait till your retirement. Start it today because it's a way of life. So if you decided to go for, even don't wait for this today's sunset, because don't let the time run out on you. Don't let time melt like ice, and don't let this time slip through your hands. Before that, go and grab that 25th hour. It may not add years to life, but I endorse that it will add life to the years, and at least it will release this medico in us who is entrapped in this 24 hours time machine. And this is the puzzle which will help you to release or escape from this blah blah. It can be done with just a single click. It will bring to the end of this particular 25th hour. Thank you very much. For me, it was half an hour of my 25 hours. Thank you so much.
Thank you, Dr. Hiren Shah, for giving a wonderful insight for creating the 25th hour of the life. To some of the things, just I would like to say, add one line, that do not love what you do, but love what you do. That is how I think things should work for you. Right? Thank you.
Thank you.
I request chairpersons to felicitate Dr. Hiren Shah.
Thank you. Thank you. Thank you very much.
I request Dr. Mehul and Dr. Chinmay to felicitate. Scientific committee of the GIMACOM is on the stage. Thank you. Thank you.
So now we have learned how exactly we should add life, happiness to the life. And so now we are heading for the PR Trivedi oration. And for that, may I call upon the stage the Dr. Jagdish Bhatt sir, Dr. Anil Patel sir, and Dr. Tushar Patel sir. Dr. Jagdish Bhatt sir is a senior private practitioner in Bhavnagar since '85. He was past chairman of Gujarat State ENT Conference, ex-president Bhavnagar Surgeons Association, ex-president Bhavnagar ENT Association. Dr. Anil Patel sir is a well-known general surgeon from Mehsana, scientific committee co-chairman, IMA GSB. He is actively involved in various social activities. Dr. Tushar Patel sir is professor and head department of TB and chest disease, GCS Medical College, Ahmedabad. He is pulmonologist and critical care specialist. There is a long list for the awards he has received. During COVID, he had received award from Chief Minister also. So there is a long list, sir. Sorry, no, I'm not going in detail about the long list. Now I hand over the mic to chairperson. Initially, I will request Dr. Anil Patel, sir, to introduce something about the oration.
PR Trivedi oration. I give brief biodata of Dr. PR Trivedi. Dr. Pranlal R. Trivedi was born in Saurashtra in 1905. He completed medical education in 1928 from Hyderabad, Sindh. In the beginning, he joined the Army Medical Corporation during Second War to recruit the medical person in the army and serve the injured personnel. He settled in Ahmedabad and served for the 12 years in Municipal Corporation Hospital and thereafter started his private practice. He is a beginning as a grass root worker of IMA. Dr. P.R. Trivedi was an institution walking on the two legs and practically built up and nourished IMA with paternal zeal and maternal love. He was a founder root worker, used to move from door to door and hospital to hospital and enrolled many members and contributed a lot to strengthen IMA during 1968. He was elected as a vice president, first World Conference on Group of Medicine held in Winnipeg, Canada during the 1970. He was awarded to BC Roy National Award for the 1976. He was an associate with the Innumerable Organization and was institutional in which institution he entered. Members of other association was collected handsome contribution in his memory, and not only in the P.R. Trivedi oration, but also P.R. Trivedi Foundation Award for branches and P.R. Trivedi Foundation Award for the individual are given every year. Thank you to all.
Today, oration Dr. Rajesh Ranglani. Dr. Rajesh Ranglani is a MS ENT DLO. Is passing from MBBS from BJ Medical College, Ahmedabad. DLO in 1998 and MS ENT in 1990 from NHL Municipal Medical College, Ahmedabad. His experience more than 23 years in his career around, he's doing more than 50,000 procedures successfully. His skill in mainly in ear, nose, throat and neck surgery, pioneer starting cochlear implant program in Saurashtra. His achievement presented many paper, tympanoplasty, AOI Gujarat at DIV 2017, delivered lecture AICOCon Indore, and also delivered lecture allergy rhinitis in GSB conference Udaipur. Also his professional fellowship at head and neck surgery from JCRI in 1993 to 2000. Also working as a tutor in Government Medical College Bhavnagar, and now he is a practicing ENT specialist since 2002 in Bhavnagar. Also a founder and director of Om ENT Sinus Clinic located at Bhavnagar. Thank you.
Thank you for the kind words, sir. Dignitaries on the dais and off the dais, dear colleagues, good evening. It's my pleasure and privilege to be here with you to express my views on obstructive sleep apnea. And I am highly grateful to the IMA, GSB and GIMACOM team for selecting me for this Dr. P.R. Trivedi Oration Trophy. Just I was listening to Dr. Hiren Shah and he was telling about his dreams. So I recall something. Sometimes our dreams becomes our nightmares. In our initial practice, we want to establish practice, we want to have money, name, fame. After 15, 20 years of practice, we start searching for locks to close our hospital for at least night time. So our dreams can sometimes become our nightmares. So that's off topic, but I thought it is interesting. So my topic today is obstructive sleep apnea. So let's start with history. So in 1956, Burwell, I'm not getting this point over here, but Burwell presented a paper on OSA. He coined that paper as the Pickwickian syndrome. This word Pickwickian was derived from a novel, the novel known as Pickwickian Papers, which was written in 1836 by Charles Dickens. So in 1836, somebody wrote a novel. In novel, there was a character known as Joe the fat boy. This Joe, as you can see in this paper, in this picture, was very fat. He was remarkable for his fat, red face, excessive obesity, sorry. And he was remarkable for falling asleep anywhere, anytime, and throughout the book, he used to sleep anywhere. He was also noted to have plethora, that is polycythemia. He was not very bright, means he might have neurocognitive impairment as seen in obstructive sleep apnea. He was short stature. As you see, children with OSA has got short stature. His picture in this picture, what we can see is his legs are edematous. It may be suggestive of long-term heart failure case like cor pulmonale. So, in 1836, a novel which was written, in that novel, there was a character which was completely resembling the person of having obstructive sleep apnea. So, this was something about history part. Now, let's go to some basic definitions to understand sleep apnea better. So, first definition is apnea. What is apnea? Apnea is the absence of breathing at the nose and oral cavity for at least 10 seconds and leading to oxygen desaturation. What is hypopnea? Hypopnea is a reduction of airflow for between 30 to 50% of normal airflow for at least 10 seconds, and which leads to oxygen desaturation for 3 to 4%. So, after understanding this apnea and hypopnea, we can come to the types of sleep apnea. There are 3 types of sleep apnea. The most common sleep apnea is obstructive sleep apnea, which I will call it now as OSA. So, OSA is the most common one. It affects around 4 to 6% of population, and it is the second most common sleep disorder. Insomnia is the first sleep disorder, and second most common is obstructive sleep apnea. So, what is obstructive sleep apnea? Obstructive sleep apnea means characterized by repeated nocturnal episodes of partial or complete absence of breathing. Partial or complete. Partial means hypopnea, complete means apnea. So, there is a repeated episodes of partial or complete absence of breathing despite ventilatory efforts. Means patient is trying to breathe. Patient's diaphragm is working, patient's muscles of respiration are working, patient's muscles of accessory respiration are working, but because of certain obstruction in the upper airway, patient is not able to breathe. So, this patient tries to breathe, his chest is moving, his abdomen is moving, but he is not able to breathe. So, this is known as obstructive sleep apnea, which leads to repeated arousals, means because of apnea, after apnea, patient arouses, and patient repeatedly gets apnea and repeatedly gets aroused. So, it leads to repeated arousal and disturbance of sleep. Coming to the other type of sleep apnea, that is central sleep apnea. So, in central sleep apnea, there is apnea, but there is no muscular movement, there is no respiratory drive, the patient is not trying to breathe. There is no breath, there is no respiration, and the patient on the top of it, patient is not trying to breathe. That is seen in some patients of cerebral vascular accidents, strokes, or some neuro problem, and some patients of heart failure, we can see such things. And there is one more type of apnea, that is mixed apnea. In mixed apnea, what we see, initially patient presents with, if you study that patient will start with central sleep apnea, then in the same apnea, patient again tries to breathe, so it becomes mixed type of apnea. So what happens in obstructive sleep apnea? What is the pathophysiology? What happens when from a wakefulness to sleep, when we pass from wakefulness to sleep, there is a first stage of sleep, it is a light sleep that constitutes around 5% of sleep, then we go to the second stage of sleep, that constitutes around 50%, that is a little deeper sleep, and then we go to the third stage of sleep, that is the deepest sleep. So, from this first wakefulness to deepest part of sleep, when we pass from this to that, the last phase, that is third phase, and another phase is REM sleep, that is the fourth stage of sleep, that is the most deepest and most refreshing sleep, and most of the repair work happens in REM and third stage of NREM sleep. So during this deepest part of sleep, and we have some decrease. We have decreased upper airway tone due to some inherent problems, as well as because certain patients have got vulnerable anatomy. This vulnerable anatomy along with the decreased upper airway tone leads to collapse of the airway. This collapse of airway may produce partial obstruction, that is hypopnea. It's not working here, but hypopnea, that is the airway is patent up to a certain extent. Or if this collapse of airway is complete, it will lead to complete absence of breathing. That is known as apnea. So we can see apnea and hypopnea picture right over there. So what happens if a person develops apnea or hypopnea repeatedly? So if patient develops repeated hypopnea, patient leads to develop hypoxia, hypercapnia, and acidosis. Ultimately, when hypoxia happens, let's say up to 90% saturation, 80%, 60%, or whatever it is, depending upon the severity of OSA, this, after certain particular concentration, brain recognizes that the body needs oxygen. So brain makes person to awake. So person becomes awake with a gasp like this. He keeps 2-3 gasps. He takes 2-3 gasps, and the breathing resumes again. Again, patient goes into the sleep, and again, patient may develop apnea, hypopnea. Again, patient goes into the gasping and choking and arousal. So it can happen, if it happens 5 times an hour. If apnea and hypopnea happens 5 times in an hour, it is normal. So all of us must have some apneas happening at some day. But if it happens more than 5 times an hour, it is considered pathological. So what happens if a person has got apnea, hypopnea of more than 10, 20, 30, 40, 50 apneas, hypopneas per hour? This person is going to have pressure, going to have a problem with CVS. What will happen? Because of constant hypoxia, repeated hypoxia, patient may turn up with systemic hypertension, pulmonary hypertension, arrhythmias, MI, chronic hypercapnia, in a very advanced stage, cor pulmonale, and sometimes sudden death in night. There is a very interesting study, I don't have a slide for that right now, but in that study they have measured the number of deaths occurring into the night. So what they measured is number of deaths occurring between 10 to 12, then 12 to 2, then 2 to 4, then 4 to 6. So what they observed was maximum deaths occurring in the night were occurring in the early hours of the morning, that is between the 4 to 6 a.m. So that is the time when we have maximum amount of REM sleep. In REM sleep, we have muscular atonia, means our muscles are not working. We have dreams in the REM sleep. Nature has given atonia to prevent acting dreams in our bed. So we have atonia, we have upper airway obstruction, we have vulnerable anatomy. All this leads to collapse of airway, and if this collapse of airway and if this apnea is prolonged for a few minutes, person may die. So even though in our culture people say, but the guy died very peacefully and he hasn't harassed his family members, but they might not be knowing that this guy was having some problem. Even though we use word sudden, it is not sudden death, because there must be many problems which were occurring, many pathologies which were occurring since months and years, and gradually it has led to manifestation on a particular night and leading to sudden death. So these were the things because of hypoxia. So what happens when patient is get aroused repeatedly? When is get aroused repeatedly, it leads to sleep fragmentation and daytime somnolence and impaired memory and recognition. Why? Because sleep is needed for our learning and consolidation of memory, as well as to remove the toxic substance from our body. So this was something about pathophysiology of OSA. Now who are the people, who are the guys who are likely to have sleep apnea? So very clear and clear cut is obesity is the strongest single risk factor for developing OSA, as well as male gender and old age. These are also contributing to OSA, because in male, there is a elderly male, they are likely to develop collapse of the tissue more compared to the females. And when person is obese, like if it is truncal obesity, that's okay, but if the obesity is spread all over the body, so the neck circumference becomes very large. If the person has a very large neck circumference of 17 inches in male or 16 inches in female with a short neck, this guy used to have a small airway. So this airway can be collapsed at any moment in a given difficult situations. As well as waist circumference. Waist circumference is also important, but in our country, in females, waist circumference is always wide compared to Western world, but we take data from Western world. That's why this waist circumference has been mentioned over here. Then there are some patients who have got a problem in their neuronal compensatory mechanism. What this neuronal compensatory mechanism does is, it keeps airway open. While we are awake, it keeps the airway open, and it tries to keep airway open while we are in sleep. But in certain patients, this neuronal compensatory mechanism is at fault and it's not working well. So this person, if it has little bit of narrowing in the oropharynx, this person may collapse very easily. As well as we have many children who are born with certain syndromes like Pierre Robin syndrome, Treacher-Collins syndrome. These children are born with a retrognathia, that is, the chin is placed backwards. So mandible is placed backwards. So when mandible is placed backward, it takes tongue back. So it actually closes the already narrowed airway. So it is retrognathia children who likely to develop OSA, as well as children with Down syndrome has got very large tongue. Because of large tongue, this large tongue obviously occupies the airway and it leads to OSA. As well as children with large adenoids and large tonsils are very much known to develop OSA, as well as certain habits like smoking and alcohol can lead to increased incidences of OSA, and hypnotics and sedatives also leads to increased incidences of OSA. So these are the risk factors. Coming to the clinical feature, what we see, what we hear from patients, what are the complaints, what we hear from patients. So clinical feature, there are two cardinal features. One is snoring, other is daytime sleepiness. Snoring is very common. At least 30% of adult males snores at a given day, any given day. Means snoring is very common. Snoring is present in OSA, but OSA is not always present in snoring, so snoring can be benign also. So the symptoms are divided into nighttime symptom and daytime symptoms. So what are the nighttime symptoms? These nighttime clinical features are not being recorded by the patient, but is being recorded by the bed partner. So what are the nighttime symptoms? Snoring, witnessing apnea, means the bed partner is witnessing that this guy was breathing loudly with loud snore. Snoring goes on, then it calms down, snoring comes down, and there is a complete silence. At the time of apnea, there is complete silence. And the person tries to breathe, but he is not able to breathe. So this is known as witnessing apnea. So snoring, witnessing apnea, nocturnal choking, because person is trying to breathe, he is not able to breathe, nocturnal choking, gasping, restless sleep, insomnia, nocturia, and bedwetting, particularly in children. In children, they develop OSA after age of around 3 to 4 years because of the adenoids go on enlarging after 3 years of age. So in children, even if the child was taught to go to washroom, later on at the age of 4, 5, 6, he start doing bedwetting. So in children, it is very important to identify the OSA because it is one of the best patient as far as treating OSA surgically. So coming to the daytime symptom, these symptoms, clinical features are being seen by patient himself. So what is the main symptom? Excessive daytime sleepiness. Means because patient is being aroused repeatedly in the night, even though patient may not be knowing that he has been aroused. But his brain knows, his body knows that he has been getting aroused repeatedly. So he doesn't have a resting, very refreshing sleep. So he has a habit of repeatedly falling asleep during the day while watching TV, while reading newspaper, even while driving, even while at work, they can fall asleep and can lead to motor vehicular accidents, work accidents, or decreased work performance. These people have got decreased libido, they are very much tired and fatigued, they have a memory impairment, they have personality changes, they have morning headaches because of low oxygen concentration leads to morning time headaches, as well as depression and obesity. Now this obesity and OSA are it creates a vicious circle because obesity leads to OSA, and a person with OSA is not able to do exercise in the morning because of tiredness and fatigueness. This guy who has OSA leads to more and more obesity, and obesity leads to OSA. This becomes a vicious circle. So these are the different symptoms to be asked in a case of OSA. So what are the examination? This is an ENT specific examination, but general examination comes first. That is to see patient as a whole, like obesity, BMI, and what is the neck circumference. Is there any cardiovascular problem or not? Is there any memory impairment? Is there any neurocognitive problem? So that is the general part. But being a ENT, I will specifically mention the examination of nose and throat. So in nose, what we see, there are DNS, there can be polyps, there can be chronic congestion of nose, there can be tumors in the nose, which can lead to obstruction of nose and sleep apnea. Alone nose usually doesn't produce a sleep apnea, but in combination with palatal problem and tongue problem, it produces sleep apnea. But nose itself is a very common organ which can lead to problems in using the machine which treats sleep apnea. So what we look is patency of nose and patency of nasopharynx. In nasopharynx, very interesting thing is that we can have adenoids in children. That we will talk little later. So adenoids are very common. Sometimes we may find some cysts, some tumors in the nasopharynx which are causing nasal obstruction. And we, being nasal breathers, we have difficulty in breathing through oral cavity and can lead to sleep apnea. What other things we look for is, we look for things in oropharynx like elongated uvula, thickened uvula, thick base of tongue, very thick big tonsils, palatoglossal muscle, palatopharyngeal muscle coming into the center from the lateral area, and there is a redundant soft tissues, redundant mucosa, fat, parapharyngeal space fat. So all these things are seen in oropharynx. So what else we can see is, we can see the larynx. In larynx, what we see is epiglottis, that is floppy large epiglottis, vocal cord palsy, particularly bilateral vocal cord palsy. If it is gradually progressing, it can present with OSA. If it is sudden, it present with stridor. Unilateral palsy, it can present with OSA or stridor. As well as I already told about retrognathia, there could be retrodisplaced hyoid complex. That hyoid goes back towards larynx and leads to decreased airway. So this was the examination part. Now, these are some pictures of oropharynx that if you can see on the right, extreme right, elongated uvula. Elongated uvula usually doesn't cause sleep apnea, but it is a common cause of snoring. As well as thickened uvula and very big tonsils, very big tongue, all this can lead to obstruction of already narrowed oropharynx and leads to OSA. Now this slide is very important because many of us, even myself, was not aware that children do develop OSA. In last 15-20 years, I came to know that children are also a candidate to develop OSA. In children, there is a particularly, they have big tonsils and adenoids, but adenoids are, as we can see, adenoids are not easy to see. So what happens in these children, at the age of 3, they start developing adenoids and tonsil in size. So it grows up to the 8 years of age. Because of this obstructing lesion in the nose, that is in nasopharynx and in oral cavity, these children do not have refreshing sleep. If these children do not have a refreshing sleep, the release of growth hormone is decreased. So skeletal growth of children are hampered. So it is very essential to identify and treat these children at appropriate age. Even though in our university books it has been mentioned that adenoids regress by 12 to 14 years, but it is not the case. I have operated many patients beyond 30 years of age also having adenoids with low stature, low height, nasal obstruction since years. So because it is hidden in a nasopharynx, we may underestimate the importance of adenoids. But these children, particularly these children, those children who has a history of open mouth while keeping mouth open while breathing, keeping head like this to breathe, they want to have airway, so they keep head like this, or they sleep on the prone side, they toss and turn in the bed, they do bedwetting, they get irritated, there will be a problem in scholastic problem, there are issues with friends. So if there is history of such thing, or if you see on the most right picture, unintelligent look with crowded teeth, with prominent incisors protruding outside, with loss of the nasolabial fold, that is known as adenoid facies. This is very peculiar phase of adenoids which are obstructing into the nasopharynx. So these children are the ideal case of surgery. In children, OSA, it is very easy to treat by removing adenoids and tonsils. So coming to how to diagnose the sleep apnea. So gold standard gold standard investigation is polysomnography, that is a sleep study. Sleep study can be done at home, can be done in labs, can be done in hospitals. So what we want to know in sleep study, we want to know whether patient has got sleep apnea, whether this is obstructive, central, or mixed type of sleep apnea. That is how to differentiate sleep apnea. And if it is obstructive sleep apnea, or if it is sleep apnea, what is the severity? Is it mild sleep apnea, it is moderate sleep apnea, it is severe sleep apnea. So what we measure in PSG is apnea hypopnea index, means number of apneas and number of hypopneas occurring per hour. If AHI is less than 5 per hour, it is normal. If AHI is between 5 to 15 or 5 to 14, it is mild type of sleep apnea. If AHI is between 15 to 30, it is moderate type of apnea. And if AHI is above 30, it is severe type of sleep apnea. Why we have to divide this? Because treatment is decided on the grading of sleep apnea. So once we conclude that patient has got sleep apnea, being a surgeon, I would like to see where is the site of obstruction. So what we can do sleep endoscopy. That is known as DICE. That is a drug-induced sleep endoscopy. So person is given midazolam, propofol or dexmedetomidine depending upon the anesthetist, and endoscope is passed into the nose and to the nasopharynx to see the site of obstruction at the time of apnea or hypopnea. So we can identify the site of obstruction. What else we can do to see the site of obstruction is dynamic MRI. In MRI, the person is slipping into the MRI machine and MRI is done. And while apnea, hypopnea occurring into the MRI machine while slipping, that MRI detects the site of obstruction. Now, you will wonder how a person can slip into the MRI. That's a question. But if you have a patient of morbidly obese patient or having severe sleep apnea, that person can sleep anywhere. Even in MRI machine, they can sleep. So coming to the management of OSA, in mild type of sleep apnea, medical management might work, particularly when we sleep on the side of our body, not on the back. There is a reduction in AHI, that is reduction of apnea, hypopnea. If we sleep on the left or right side of our body, that is one of the standard treatments, one of the standard advice given to persons who have got mild sleep apnea. Other most important advice is to reduce the weight, because obesity is the strongest risk factor for OSA. Apart from that, simple treatment like treatment of nasal allergies, a simple nasal obstruction can be treated very easily, as well as asking to avoid alcohol, smoking, and asking to avoid them sedatives can improve their sleep apnea, as well as following a sleep hygiene is also very important. There are many number of appliances available on net which keeps your mandible forward, which keeps your tongue out, but I haven't seen many people using that. It may work in mild type of sleep apnea. So what is the gold standard management of sleep apnea? The gold standard treatment of sleep apnea is CPAP, that is continuous positive airway pressure machine. What you can see in this picture, a guy is wearing some nasal mask that is attached to a machine that is known as CPAP machine. What CPAP machine does is it gives air at a certain pressure depending upon the requirement of a person. So it gives up air at certain pressure. So when this air is given at a certain pressure, on the extreme right picture you see with a mask, what happens? The airway opens up. It leads to pneumatic splint. So the airway behind the soft palate and tongue opens up, and patient is able to breathe normally, inspire normally. So this is the gold standard treatment of sleep apnea, any form of sleep apnea, OSA or central sleep apnea. We have different types of CPAP like auto CPAP, fixed CPAP, BiPAPs, and many other variations are mobile CPAP. There are many other variations available. Coming to the surgical treatment, surgery is the primary mode of treatment in children. In children, they are not offered any CPAP, but because the reasons are very clear and treatment is very rewarding, in children, adenoid and tonsil removal is the ideal thing to do. In adults, it may be salvage treatment, because in adults, usually first treatment offered is CPAP. If patient is not tolerating CPAP, or if there is mild sleep apnea between 5 to 15 episodes per hour, if there is AHI is less than 30, so we can operate also. There are many surgeries developed for this that suggestive of surgeries are not working well, because lot of variations are there, lot of surgeries have been developed, but there are some stringent criteria to select a patient for surgery. Then only it can give good results. So which are the stringent criteria? BMI less than 32, AHI less than 30, and no nasal obstruction. If it is there, we can treat the nasal obstruction. And there are Friedman tongue positions like this. If you see stage 1 and stage 2, upper two pictures, you can get good results in surgery. If you go for lower two pictures, you get very poor result of surgery. So there are many surgeries like nasal surgery, palatal surgery, tongue surgery, laryngeal surgeries, and many surgeries are done to increase the airway. We will try to see a video. How it will, excuse me, how will it start? Start? Okay, fine. So this is a sleep endoscopy. A person is under sedation. Patient is under sedation. Nasal endoscope is introduced. And what we can see, what we can see, this is a nasopharynx. Nasopharynx. So what we see in nose can be seen without sedation also. What we want to see is movement of soft palate and movement of tongue. Because movement of soft palate and tongue are been visual. This is the vocal cords, what you see right now. So this, one of the common reason of snoring is soft palate, particularly uvula. Movement of uvula in a, what you can see, can you increase the voice? The movement of uvula into the air produces snoring. Decrease the voice. Yeah. So this is the sound which is produced in the snoring, but snoring itself is not a OSA. Snoring is very common. Snoring itself is not a disease, but it can be a problematic to the bed partner. So we have tongue, which can be large, which can be displaced backwards, which also can lead to obstruction of airway. Like in this case, what you see, tongue is going back towards larynx and causing obstruction of airway. This is the back of larynx. What has been shown is with red arrow. This tongue is going back, pushing the larynx back and closing the airways for few seconds. Can you increase the sound, please? Okay, fine. So there could be a problem at the level of larynx. Means arytenoids, because of arytenoids are closing, coming into the larynx itself while breathing in. In inspiration, actually arytenoid should go out, should go laterally to open up the airway. But in some patients, this arytenoids, this vocal cords sinks in and causes airway obstruction. So this is the obstruction at the level of larynx. So there are different treatments available for different obstructions. CPAP is the gold standard, as I was told. Different types of surgeries can be done depending on septum, turbinate, nasal polyp, adenoid, soft palate, uvula, tongue, back of tongue, lateral wall of throat, as well as on the larynx. So these are the different surgeries we can do in different types of cases. So last two slides. This is very interesting studies have been done. In this study, what we can see is independent predictors of myocardial infarction. When you consider odd ratio, you can see that an overweight person has a 7.1 odd ratio, hypertensive has got 7.8, smokers have got 11.1, and OSA has got 23.3 odd ratio to develop myocardial infarction. So we have to understand that OSA is a very serious disease and needs to be treated aggressively and need to be identified aggressively. And there are studies which have measured the prevalence of OSA in different diseases. So when you see a person with hypertension, there are 30% chance, 30% of patient might have OSA. When you see a patient of GIRD, there may be 60% chance of 60% persons who can have OSA. And same thing, depending upon different disease, there is different percentage from 30 to 90% of patients can have OSA. So OSA is very important. Just a minute. So OSA is very, very important and very deadly disease. And as India right now has a big young population, within 20-30 years we have more older population, as well as our socio-economic condition is improving. So we may have pandemic of OSA within 20-30 years because increasing age and because increasing improving social economic condition will lead to obesity, as what has happened in Western world. So we may have pandemic of OSA after 20-30 years. As well as if you see the prevalence of OSA in surgical patients, when there is a person taken for bariatric surgery, among the all bariatric patients, 80% patient will have OSA. Among the all elective surgeries, 25% number of patients may have OSA. Most of the cases are underdiagnosed. and it is associated with myocardial infarction, hypertension, and other comorbidities, as well as neurocognitive problems. And early diagnosis with the help of polysomnography or home-based sleep studies is very easy and can be done with ease. And CPAP is the gold standard treatment of OSA. Surgical management may be important in certain class of patients. In very few selected patients, it may give very good improvement. Thank you very much for kind listening.
We warmly welcome our Honorable Municipal Commissioner Shri Upadhyay sir. Team GIMACOM આપનું હાર્દિક સ્વાગત કરે છે.
Thank you, Dr. Ranglani. Take home message is if you see a obese person and a child with less intelligence, please refer to INT surgeon to rule out OSA.
Now I request chairperson sir to honor the speaker, Rajesh Bhai. I request Dr. Nidhi Vasani ma'am to honor the chairpersons. Thank you, Dr. Rajesh Bhai.
Chairpersons are Dr. P.L. Sachapra sir and Dr. Subhash Telang sir. I request both of them to come out to the stage. Dr. Sachapra sir is a very senior physician. Done his MD from the MP Shah Medical College, Jamnagar in 1989. He is the life member of the Cardiological Society of India and Indian Society of Echocardiography. Presently, he is working in a private Samarpan hospital and ICU, Arogyam. Dr. Telang sir is a well-known cardiologist in St. Nanavati Hospital, Mumbai. Has worked as a cardiologist at St. Nanavati Hospital, Mumbai. Won Best Paper Award in APG conference and practicing as non-invasive cardiology since 39 years in Bhavnagar. I request chairpersons to take over. Please, sir.
Dr. Rohan Parikh sir. He had completed MD Medicine in 2014 from BJ Medical College, Ahmedabad, and DM Cardiology in 2017 from Government Medical College in Nagpur. Since last 5 years, he is working as a consultant and interventional cardiologist at Akanksha Hospital and Research Institute at Anand. Sir's interest in academy and research field made him more than 50 achievements in different kind of medical activities. He had around 36 international publications also. He also wrote a chapter in the book named Current Status of the Drug-Coated Balloons. Now, his session is a sudden cardiac death. I congratulate and I thanks GIMACOM for choosing this chapter. This sudden cardiac death is a growing concern. In Indian Heart Journal, January 2014, it has been mentioned that around 7 lakhs sudden cardiac death annually in India. And it not only the general publication, general public, but also it is concern for we all together. So I thanks GIMACOM for arranging this lecture. I invite Dr. Rohan Parikh sir to address his session and to uplift our knowledge.
Before, I would also like to invite Dr. Shailesh Shah as a chairperson, who has been a vice president of Gujarat State IMA branch and national vice president IMA headquarter Delhi, who is also winner of KJ Nathwani Award for social activist twice. Welcome, sir. Okay. Now you may proceed.
Good evening, everyone. We are already running late in the session. The 5 p.m. was the time for inaugural ceremony. So I'll try to be as brief as possible and as memorygenic as possible so that we all take good message home for sudden cardiac death. Sudden cardiac death, what is the problem? It is there since years. Everybody knows there is something problem. Everybody dies suddenly. I'll not take anything, any definitions, no textbook pictures, nothing.
सेलिब्रिटीज को सदमे में डाल दिया है। आपको बता दें कि केके का निधन कोलकाता में हुआ, जहां वो एक कॉन्सर्ट करने पहुंचे थे।
You keep the sound, no problem.
Former Indian President APJ Abdul Kalam passed away today in Shillong. He was 84. Earlier, the missile man of India collapsed during.
So, this picture, we should be thrilled. There should be goosebumps on our hands. You know, President of India dies of sudden cardiac arrest while giving a lecture in Shillong. What bad can you expect than this? President of India, nuclear scientist. He is not a lay person. He is intellectually very powerful. So if he cannot predict his cardiac arrest, who else? You have a full team, full ambulance, full backup facility, full medical assessment to President of India. Still he could not be revived from stage. If we come back to this, singer dies, that's okay. A singer could not be revived because he does not know, maybe probably he must be suffering from other diseases. We know page 3, Bollywood stars, they may have other ill habits, and we can enumerate other reasons for his death. What for this great man? Dr. APJ Abdul Kalam dies of sudden cardiac arrest and could not be revived. हंसे अनु घर वसे.
अब हमारे बीच नहीं रहे हैं ये देश की एंटरटेनमेंट इंडस्ट्री.
Can you laugh more than this guy? He died of cardiac arrest. 3 times he had MI, could not be revived. Lastly, he died in AIMS with myocardial infarction. So, these 3 pictures should be at least enough to remind us that sudden cardiac arrest is still an unaddressed issue and it needs an important, intelligent and important working towards it. This is how media reports sudden cardiac death. Sridevi dies in bathtub. A school-going children dies in an exam, 9-year-old. Siddharth Shukla, Big Boss winner, dies after winning a trophy. My senior from UN Mehta, he absolute senior, 4-year senior to me, interventional cardiologist, one who deals with sudden cardiac arrest and myocardial infarction day in and out. Media reports more than 16,000, probably 16,000 angioplasties he must have done in his first year itself of residency. So that must be 16,000 in private practice. Media reports, it is not only, it's not shocking, it is painful. When you see your near dear one dying of untimely death, unexplained death. A doctor, 30-year-old pediatric surgery resident in Delhi, dies of sudden cardiac arrest. So then you have papers. Whatever extracts I have taken, they are no late than 2023 September or August. Whatever extracts I have taken from newspapers or journals, they have been taken from past 3 months. So these are all latest papers that have come up. Sudden cardiac death, early death among medical professionals. We are worried because now medical professionals are also being inculcated or also going through this sudden cardiac arrest. That is creating a problem. Anytime the public had cardiac arrest, but they were not picked up. Now it is creating a havoc because now sudden cardiac death is happening among medical professionals. So there is news, the papers have come up in lay print, in general media also, where doctors are trying to address their faculties, their colleagues about early deaths among medical professionals. But this is how we report. This is how medical professional reports, or this is how scientists report. How sudden cardiac death happens, athletes and dancers. ગરબા થાય એના ગરબામાં સ્ટોલથી પાપડીના લોટના સ્ટોલથી વધારે એમ્બ્યુલન્સ ઊભી હોય છે. Why? Because the sudden cardiac death arrhythmias have increased in dancers. So there was a paper, cardiac tuberculoma, TB, age-old disease, presenting as sudden cardiac death because of arrhythmia. So cardiac tuberculoma causing sudden cardiac death. Energy drinks, causing there has been comprehensive review on this, where different energy drinks causing arrhythmias and sudden cardiac death. There are specific genetic mutations also, which are pertaining to proper geographical region, where like China, India, there have been various gene studies also that have identified the special population that are at higher risk of having sudden cardiac arrest than others. So there have been multiple papers over years, nothing new in sudden cardiac arrest. But why this topic is still hot? Why everybody thinks that sudden cardiac death, which has increased post-COVID, was not there pre-COVID? A commotio cordis, very funny term. If you hit somebody on the chest, somebody may die of sudden cardiac death. There is no trauma to heart. Actually, pathologically, if you see, there is no pericardial damage, there is no rupture of cardiac wall, there is no hemopericardium. But suddenly, because of trauma, there is cardiac standstill. That is called commotio cordis. This is common among rugby players. Rugby players fighting for ball, if they get a chest trauma, they can suffer commotio cordis and there can be sudden cardiac death. There have been congenital heart disease which can cause sudden cardiac death. They have malignant arrhythmias. There are multiple genes also which have been identified that among the group of congenital heart disease, there are specific populations which have higher risk of having sudden cardiac death. Spontaneous coronary artery dissection. This has been known in years. Most common among pregnant females. Pregnant females, they do suffer spontaneous coronary artery dissections and they die suddenly. There have been pediatric cases as well. At times, when in the neonatal ICU, you cannot revive a kid. We try to label them as, this is probably maturation is not there, there is lung problem, there is tachypnea, so the newborn surfactant issues. But there have been genetic studies which have proven that there are myocardial hyperplasia, there are intercalated discs between two muscles, where mutation in that can also cause sudden cardiac arrest. So sudden infant death can be because of this. So recently a systemic review is complete analysis of whole RCTs and individual cases that have been published over years. That systemic review was published in the journal in August 2023. Out of the 7 international centers, 2 are Indian centers, JJ Hospital Mumbai and Safdarjung Hospital Delhi. So these 6 centers all together put up a paper on sudden cardiac death, because this is now we think that this topic has been revamped after COVID. After COVID, probably there is a surge in sudden cardiac arrest. Probably we are worried because there is a surge in sudden cardiac arrest among doctors post-COVID. That is where we are now worried more of this sudden cardiac arrest. So COVID, you label everything and there is COVID. In residency, we were taught that if you cannot find anything, tuberculosis is the cause. So now probably if you cannot find anything, COVID is the cause. But there are some papers also to back this. So there are COVID which can cause myocarditis, which can cause inflammation of the heart, and there can be sudden cardiac death. It can cause arrhythmias. This is most dangerous terminology, long COVID syndrome. Long COVID syndrome is long COVID syndrome. So if somebody has suffered from COVID, after few months also, they can suffer from arrhythmias. If they are atrial fibrillation or atrial tachycardia, that's okay. But if there is ventricular tachycardia, there can be sudden cardiac death. So the puzzle, why after COVID, why after so many months, why after receiving anticoagulation also there is sudden cardiac death in COVID patients because of long COVID syndrome. There are arrhythmias, they make person pro-arrhythmogenic, and of course there are some genetic inherent characteristic of an individual also which is responsible, but post-COVID, most common is this long COVID syndrome which is causing sudden cardiac deaths. COVID and heart failure, as similar to as rest of the pneumonias, any pneumonias in any cardiac patients, sick patients, already compromised heart, they are more likely to suffer from heart failure, whether it is preserved ejection fraction or that reduced ejection fraction. So COVID can cause myocarditis, can cause arrhythmias, it can cause heart failure. If COVID is not enough, vaccination of COVID is also equally responsible. Now, is it fair enough that you label everybody receiving vaccine and die suddenly to be dying because he has received vaccination? This is common. This is not among not only non-medical professionals, even medical professionals. This is the problem. When we are not able to explain, we have to go into the depth. There has to be verbal autopsies. And before labeling anything responsible to only one thing, there has to be other detailed discussion. Like there have been papers where suddenly after receiving a Pfizer vaccine from COVID, the person dies. Actually, when you do a postmortem, you find that patient already had a Brugada syndrome. There was already an arrhythmogenic precondition existing, and probably because of vaccination it has been. But what is the prevalence of Brugada? It is 1 in 1 lakh in Asian population. It is very rare in Europe. So if for this you prevent somebody taking COVID vaccine, how can that be justified? Where COVID kills more than 10 in 1,000. Similarly, multi-organ inflammation, one of the Japanese girl, 9-year-old, dies of COVID vaccination with multi-inflammation syndrome. Now that is the only case that has been reported. But there are cases. So probably we need to study the problem with sudden cardiac death is the proportion. The proportion of person that suffer cardiac arrest due to our specific etiology is very rare. So it is becoming difficult to decide a policy, to make a prevention strategy. That is the bottleneck of sudden cardiac arrest. Because you cannot pinpoint one etiology. It is rare, and among those rare also, to track when will they have cardiac arrest is also very rare. So to trace such persons, to trace such scientific data is very difficult. And that is why we are falling back in COVID. The pathophysiologically how COVID has made us prone to cardiac arrest is it causes endothelial dysfunction. It causes thromboembolic phenomena, not only in coronaries, carotids and peripheral, but they give you time to reach hospital. If it happens in coronary, that is sudden cardiac arrest. It has happened in infant also, fetal thrombogenic microangiopathy, causing sudden cardiac death in an infant post-COVID. There have been myocardial infarctions in post-COVID. Similarly, some persons receiving vaccination, they also exhibit some thromboembolic phenomena. And then there have been series that have been studied where actually autopsies have been done to see why there was some persons have probably more risk of thromboembolic phenomena than other. So is it only COVID and COVID vaccination that has changed the scenario in last 2 years? Why we forget about air pollution? Recently, yesterday only in Times of India, there was an article where the National Atmospheric and the Meteorological Society has stopped sharing data for Delhi city, that how much air pollution is there since October 19. So that means the level of air pollution is crossing the limits. Air pollution causing sudden death. This paper has been published in October 23, 17th October 2023, Current Environment Health, where there has been systemic review how air pollution causes sudden death. There are various aerosols. Maximum study has been done in China, where 2.5, that is called 2.5 ppm, which causes maximum problems in cardiac patients. There have been paper where actually people have advocated for air pollution being listed in death certificate as the cause of death. To that amount the research has gone. So there are various fine particles which are responsible for such type of cardiac arrest and sudden cardiac death in air pollution limited cities. It not only thromboembolic phenomena, it also causes cardiovascular aging. So inappropriate atherosclerosis at younger age, that is called cardiovascular aging. When we do an angiography, we usually expect in 30s and 40s to have clean coronaries, plaque at only one location. But now in 30s also, you see a diffuse atherosclerosis, as if you are doing an angiography on an 80-year-old man. So that cardiovascular aging has started probably because of air pollution. If air pollution is not enough, organic farming, pesticides, there have been multiple studies in sub-Saharan Africa as well, which have correlated pesticides with cardiotoxicity. I'm not talking about something which are cardiotoxins, proven cardiotoxins like aluminum phosphide. There are pesticides which are routinely used in farming are responsible for pesticides. Now, how to study those? Sometimes when their autopsy has been done, probably there was not the data to search for those specific pesticide or those chemical. So there has been specific field that has developed that is called forensic entomotoxicology. So the area where there is sudden increase in cardiac death, there has been field where you study the insects in the same area and you study the chemical composition of that insects that are suffering from cardiac deaths. So that insects give us the idea what a human population suffers from the same environmental surrounding. So forensic entomotoxicology has also come up to study sudden cardiac deaths. So pesticide exposure and genetic amalgamation has responsible for DNA damage and sudden cardiac arrest among humans. Come back to our old Ayurveda. We start everything from gut and ends in gut. So there has been a paper which has been published on human gut microbiota. Just like there is DNA, we all have genetic book where we have some more than 10,000 genes which are responsible for some specific function. There are human gut microbiota also, which have been now equally held responsible for multiple diseases and equally so for cardiac diseases. So not only heart failure, cardiac arrhythmias, but also sudden cardiac deaths. There have been multiple studies, there have been case reports, and there have been in ex vivo studies also of human microbiota, where they have been trying to relate human microbiota and a cause of sudden cardiac arrest. They are not only responsible for that, they are also responsible for drug therapy. So this is a typical angiography post-COVID. Young male proximal LAD, if you can see, there is a huge thrombus that is causing, this is ostial LAD. If this patient would have not reached hospital, he would have suddenly died, because this is the location where there is sudden cardiac death if there is atherosclerosis at this location. So ostial LAD, what as an interventional cardiologist, we are fond of putting stents when we find lesions. But in a young male, you see this is a COVID patient. What we try to extract only the thrombus and leave coronaries as it were. This is coronary that has been left there. This is the thrombus that I extracted from that gentleman who presented to me with acute interval MI with 20% ejection fraction. Now post-discharge, now it has been 2 years almost. His ejection fraction is 60% without a stent in coronary, normal ECG and normal echocardiography. I have not done anything, only I did was this thrombus extraction in a COVID positive ST elevation myocardial infarction. Now, unfortunately, this is angiography 3 days back done at my hospital on my batchmate with whom I have studied in school. If you see this angiography, there are multiple regions. There is no thrombus. There is atherosclerosis in left circumflex. There is atherosclerotic lesion in right coronary. There is a severe diffuse atherosclerotic disease in LAD. If I am not given the age, I would probably expect this is 70-year diabetic patient who is presenting to me like this, where it is typically a triple vessel disease requiring coronary artery bypass surgery, CABG. 36-year man, my school batchmate, no other ill habits. He's an entrepreneur by profession. Yesterday, he underwent bypass surgery at my hospital. So now, what do we expect? He did not die. He come to us, probably we saved. Otherwise, there would be a WhatsApp video of my friend itself. Luckily, he was not there in WhatsApp video. He's there as a patient in my hospital. It shocks you to the core that cardiology and sudden cardiac death, the proportion and the increasing number, and now it is happening to your near and dear ones. So who is he? They are cardiologists. Every time there is death, the death certificate has to be filled by a cardiologist. So Yamraj is sudden cardiac death. When we are doing residencies, every time whenever there is the mortality meet and you come up, it is always the physician who is held responsible. Even patient having polytrauma, maxillary cancer, ultimately you die only because your heart stops, whatever is the cause. So ultimately whatever happens, your death certificate has to be filled by a physician and more so by a cardiologist. So this is the sudden cardiac death. So what is shocking? Of all the deaths, natural deaths, 70 deaths are cardiac. They are cardiac. What is more shocking? 50% of all cardiac deaths are sudden. Sudden means you don't get a time to reach hospital. If you reach hospital, doctor don't get time to revive you. If you reach hospital, your colleague, your senior, your junior cannot revive you. That is sudden cardiac death. Majority, this is not the statistics of India. This is the statistics of world. 70% of natural deaths, sudden cardiac arrest out of 50 which are sudden. Now read third line. 50% of all sudden cardiac death are the first expression of their underlying disorder. So what is the first symptom? Death is the first symptom. What bad can you have expect than this? Even if you have cancer, you go to Shailesh Shah sir, you will probably have some symptoms. Prognosis may be good or bad, but you got a time to reach to the doctor. 50% of sudden cardiac death, they are the first manifestation of your underlying disease. How can you pick up a disease where they don't give you symptoms? So now 50% of all sudden cardiac deaths are coronary. That everybody knows. If it is cardiac arrest, majority are because of coronary events. So these are multiple causes of sudden cardiac deaths. Put apart the textbook anomalous coronary arteries, Brugadas, that are responsible in infants and young and toddlers, more common dilated cardiomyopathy and valvular heart disease in elderly. The problem is young age. The problem is 50% of sudden cardiac death take away your potentially active life years. That is the problem. You die at the most active part of your life, where your family depends on your occupation, your earning, your livelihood. And then there is a sudden cardiac death. That is the problem. So these are pathophysiology where there are multiple arrhythmias, pulmonary hypertension, other structural problems in heart, and this is coronaries. Now pay attention to this. This is a textbook picture of Robbins where everybody of us have read this Robbins in second year of MBBS. Now, can you tell me this? The second stage is pre-atheroma stage. That means already there has been some lipid deposition in the arterial wall. That is the first sign of atherosclerosis. So at what age we have the stage 2? At what age we will be at stage 2? Everybody would wish that we will be at stage lesion 2, type 2, where there are some macrophages but no lipid deposition. So this stage 2, 90% of infants reach stage 3. So by 1 year of age, we have started to develop this atherosclerotic lesion and cholesterol deposited in coronary arteries. So the only question is not, will I die of cardiac arrest? The only question that remains is, when will I die of cardiac arrest? Everybody is destined to die. The question is the stage from 3 to 6. What is this journey? When will you reach this journey from 3 to 6? When will this graph reach there? When will be there plaque rupture? Is there anything in between stage 4, 5, 6 we can pick up? What if, can we do anything where we can stop this and we don't get sudden cardiac arrest? At least 50% of those sudden cardiac arrests which are coronary events, which at least coronary events we can pick up. If that we can pick up those coronary events, we can at least reduce those 50% of sudden cardiac deaths. So what investigation you should do? So we all know that the investigation starts with history. So these are age-old various risk factors that have been studied. So these are risk factors. Suppose patient comes to your OPD, or you think of yourself. You have to take 15 minutes to take the history, family history. You have to take multiple blood parameters and then plot somewhere this. There have been multiple applications, there have been multiple software also where you can put the data and they'll give you one figure which is approximate risk of having a sudden cardiac arrest in next 10 years. So these are multiple that are known. There are multiple genetic studies also which have been done where they have been related. So what we should do? ECG, echo and treadmill, right? This treadmill was after Notebandi, but pre-Notebandi there were different treadmills that were available. So which type of treadmill you want to undergo? You know, treadmill can pick up if you have severe triple vessel disease at a sensitivity of 70% with specificity of 80%. So if your treadmill is positive, you already have triple vessel disease. So if you want to screen somebody, ECG echo would definitely, you don't have a lesion, so ECG echo is normal. But treadmill, if you have 90% lesion in one vessel, then also your treadmill will be normal. So this is an inefficient investigations anyway. There have been CT coronary calcium score which has come up. What is more important? You start screening when you first put the statin on the neonate. That is the most important thing. You take verbal autopsies. When natural deaths happen, we should try to correlate what is the probable cause. These are multiple genes that are now commercially available. You can get your genetic testing done so that you know that whether you are at risk of cardiac arrest or not. So this is at my stage where we give CD. So if you have CD with anybody, you know that patient has undergone an angiography. But there will be a future if you have CD, you know that your kid is born and he has been given a CD where you have genetic composition of the big kid with you, and you know that this kid will suffer sudden cardiac arrest at the age of 40, or he will have familial colonic carcinoma at the age of 45. This stage we have to reach. The problem is, if you have diagnosed everything, even if you advise somebody something like exercise and all, they'll still go to the pharmacy. They want everything which can be chewable pill. They don't want to put efforts for an exercise. So what is the most important thing to prevent coronary activities? Exercise, exercise, exercise. What is most important? Can one test diagnose everything? Can one treatment fit everything? Can one worker do all the job of your factory? No. So everything put together is important. So what should you do? So this is an algorithm. We are at this stage, late stage, where we diagnose somebody coming with acute event and then we treat with angioplasty, aspirin or something. We hope we reach someday where we can pick up pathological risk and we can modify them in their secondary prevention at age of 20s and 30s. If science advances more, we can pick up at day one of life where there are antisense genes which have been identified.
Conclude as early as possible.
So this is anyway my last slide. Lancet has Yes. Sir, there is one wonderful comment that was given by one of the cardiologists from AIMS. He was asked that how important is dehydration. So he said, if you are a brand ambassador of an energy drink, or if you are a brand ambassador of a water company, then probably dehydration is very important for you. Otherwise, if you have dehydration, the moment you will have thirst, you will drink water. So there is no dehydration. We are that sense. Only if you become unconscious or altered sensorium, you cannot perceive your dehydration. The moment body has dehydration, you will have thirst and you will drink water. So no dehydration is responsible for plaque rupture and atherosclerosis unless you are altered sensorium and unconscious. So the problem with all of us is this: we all become Babulal of Bazigar. We want to push Khilli on the opposite wall. We try to diagnose everything in our patients, but have we ever retrospected us? What is the risk of our sudden cardiac death? When will we die of sudden cardiac arrest? So what is most important is, since I started talk, it was 5 p.m. now, this is 5:20 probably, 20 minutes, 35 minutes. 35 minutes we are closer to our grave. So what is ticking away is not the time, what is ticking away is your life. So what Hiren Shah sir told, give importance to your life. Medical field, everything will goes off. So suppose tomorrow morning you wake up. 250,000 people die every morning. So it may happen with a cardiologist, it may happen with all of us. Suppose morning you wake up, you must give yourself a big smile. That is, at least you are alive today and you don't have suffered a cardiac arrest. Thank you.
Thank you, Dr. Parikh. Thank you, Dr. Parikh, for your good lecture on this sudden cardiac death.
Just a minute of interruption.
We all have to find out in every person we examine for any abnormal causes which can lead to sudden cardiac death. Thank you.
We would like to honor and felicitate our guest for today, Nek Namda Yuvraj Jaiviraj Gohil sir. Thank you so much for joining us for this session. And when we were talking about exercise, we have a fitness icon right with us today. And we really feel honored and blessed to have you, sir. So you can carry on, please. We request the chairpersons to felicitate the speaker. And we would request our past president of IMA national level, Shri Kanani sir, to join the august guests and to felicitate the chairpersons, please. Dr. Kanani sir. Dr. Samir Joshi sir, who is managing the toughest call of the conference, he is the treasurer. So we'll call upon our finance minister to join Dr. Kanani sir. all dignitaries on the dais and off the dais. Here we are at the end of this scientific extravaganza. We express our immense gratitude to all of us for participating wholeheartedly in all our scientific sessions since morning. And we promise you that the weekend ahead is going to be productive and fulfilling. So keep tuned and keep joining us. And before we call it a day, a big thank you from me, your host and host for today, Dr. Nidhi Vasani Iyer, Dr. Ranjit Chaudhary sir, and Dr. Kailash Bhalani, who have joined me in making this session really wonderful for all of you. At the end, I would like to quote Winston Churchill. This is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. So moving on to our next session, we hand over the dais to IMA GSB to take the proceedings further. Over to you, sirs.
We are handing over the mic to the Dr. Urvesh Shah and Dr. Ashish Bojak for the next session.